Good morning. My name is Alan Weil. I'm editor-in-chief of Health Affairs. We're thrilled today to be releasing the November 2015 issue, Food and Health. This is a first for us at Health Affairs to have an issue focused on food, and it was a pleasure to put it together. One of the exciting things about the topic of food is that although much of the attention appropriately has been on the relationship between obesity and health and eating and obesity, this turns out to be a multidimensional topic. And what's great about putting together a thematic issue is that we get to come at it from so many of the different dimensions. And that's reflected in the papers included today. It's reflected in the agenda that we've put together for the briefing today. So after a panel on obesity, we'll also be talking about the critical relationship between food insecurity and health, knowing that in a country with excess, we also have many people who suffer from food shortage and insecurity, and we have documented a relationship between that and people's health. We'll talk about health systems, food production. We have excess and the waste associated with that, and examinations from a global and a domestic perspective on how health systems and food systems can function more effectively to promote health. There's been a great deal of attention on the topics of food purchase, both at the restaurants, which are an increasing source of food consumption for Americans, and so there's a discussion of papers related to restaurants and food labels, and of course food shopping, the term that's entered the lexicon of food deserts, looking at changing patterns in how people purchase food, where they purchase it, and how where they purchase it affects the kinds of foods they buy. All of these are different dimensions of the topic of food and health, and all of them will be covered today. Today's issue and today's briefing is one that we hope you will follow and tweet. Use our handle at Health Affairs. The hashtag for today is slightly misstated on the screen. It's #HA_food health. We hope you will tweet out at HA_food health. I mentioned to you many exciting elements of the issue today, but there's one new feature in Health Affairs that we are releasing today for the first time in the November issue, and that is our data graphic. This will appear not every month, but periodically in the pages of the journal. It's an effort to bring together evidence and data, research findings from across a topic, and in this instance, of course, also drawing from multiple papers in the issue. We have just released our first, and we're very pleased to be able to do that in this and future issues. Now, typically, we hold our release event the day after the issue goes public. Due to scheduling primarily the American Public Health Association meetings in Chicago, we actually delayed our release by a day. And one of the great benefits of doing that is that we've already been able to observe how much attention the issue has generated. Typically, we're here just starting the buzz. We're now 24 hours into it. Every major television outlet, every major media outlet has picked up one or more stories from this month's issue. The data graphic that you see up here on the screen is the hottest item on our website associated with this issue. The Twitterverse is alive with reports from various papers in the issue. It does seem to be Food and Health Week, and so we're definitely a major part of that. We actually hand-delivered copies of the November issue to the First Lady's office at their request. We are really pleased to be able to say that when we publish in Health Affairs on a topic, there really are two hits. One is the immediate attention that comes out through events like this in the media, but the other is that we're contributing to the literature for the long run, and I'm confident that the constellation of papers in this issue will serve both ends, both to elevate the issue today as well as to illuminate our understanding of the issue for many years to come. And that's what we do so well at Health Affairs. We can't put on an issue like this without significant support, and we are thrilled to acknowledge the support of the Robert Wood Johnson Foundation as the funder of this issue. It's great for us to have their support, and of course it's their support that also made it possible for us to do new features like the data graphic and the event today. I also want to acknowledge Bill Dietz, who served as a theme advisor overseeing our review and editing of all of the papers. And so with that start, it's my pleasure not just to thank the Robert Wood Johnson Foundation, but to welcome Abbey Cofsky, a Senior Program Officer at the Foundation, who leads the Foundation's County Health Rankings and Roadmaps program and the efforts there to catalyze demand for healthy practices and places. She joined the Foundation in 2007, coming from working in the Philadelphia Department of Health. Abbey, we're really thrilled to have not just the support of the Foundation, but your presence here, and I'd ask you to introduce the topic for us.
Good morning, everybody. So I want to thank Alan for that thoughtful introduction, but also for all of the work and creativity that has gone into this issue on food and health. Also for what clearly has already been a successful launch. We at the Robert Wood Johnson Foundation have supported and have been privileged to call Health Affairs a partner for a long time, because we know that Health Affairs is publishing some of today's most compelling research on the most timely and topical health issues. And just as importantly, maybe even more importantly, we know that Health Affairs is committed to ensuring that the research informs policy decisions and debates across the nation, decisions that we know are being discussed today. And these are decisions that are really about creating better opportunities for health and ensuring that people's lives are better. So simply put, this work has impact on millions of Americans across the nation, and we want to thank you for that. So those of you that know the Robert Wood Johnson Foundation know that our core vision is to build a culture of health, a culture where getting healthy and staying healthy is a fundamental and guiding social value. And we know that in order to do that along with so many partners, this type of research is essential. This past year, following the announcement of our new orientation to a culture of health, we also announced a $25 million commitment over the next 3 years to fund innovative research on policies, laws, and community factors that can improve health and well-being. And with this commitment, we are prioritizing how to improve health and well-being with a focus on those sectors and those issues beyond healthcare, those factors that we know so profoundly influence health. Transportation, housing, other social, economic determinants of health. Because we know, and you know, these critical factors like the food system, the way that they impact our health. This research commitment is being spearheaded by 3 new programs. The first, Evidence for Action, which is investigator-initiated research to build an evidence base for a culture of health. It's being managed by the University of California, San Francisco. The second, Policies for Action, will explore policies, laws, regulations, as well as business practices and how they can support a culture of health. And this work is based at Temple University. Finally, Systems for Action at the University of Kentucky, which is investigating how to align public health efforts with healthcare, social services, and other community systems. So I share this update with you to note that the first of those programs, Evidence for Action, has proposal opportunities open right now. So I encourage those of you that are interested to take a look. But I'm not here primarily to talk about our investments in research. I want to come back to the Foundation's commitment to build a culture of health, a commitment that has been driven in many, many ways by our decade-long focus on addressing the issue of childhood obesity. And we know that research and building the evidence base has been an essential component of our efforts to ensure that all children grow up at a healthy weight. We have funded efforts to examine what it will take and what works to help children eat healthier and move more. And we take great pride in the progress that we, along with so many researchers across the nation, have made. But as this issue on food and health points out, there is still a lot of work to be done. We know that 1/3 of children and teenagers in the US are overweight or obese. And while this rate has been steady for recent years, it is still far too high. The latest data from our State of Obesity report, a report that we put out with Trust for America's Health, shows that 3 states now have adult obesity rates that top 35%. These are disheartening numbers. And we know that the toll of obesity, both in terms of morbidity, mortality, and the cost of obesity, well, these are all well documented in this issue, and these are the reason that we are still committed to confronting the challenge of childhood obesity. Now, we are encouraged by those steadying rates. We are also encouraged by communities and leaders around the country that are drawing from the evidence base and putting changes in place, changes to the environment, changes to their policies across multiple sectors. In Kearney, Nebraska, public schools have opened fruit and vegetable salad bars and started walking and running clubs after school. Anchorage, Alaska, adopted a comprehensive school wellness plan a decade ago and participates in a statewide campaign encouraging families to be active and to cut sugary drinks. Vance County in North Carolina has made roads safer for pedestrians, started farmers markets, and begun working with local churches to designate health ministers in their congregations. These may sound like small steps, but these are the steps, these are the contributions to creating a culture that does prioritize health, creating a culture that makes the easy choice the healthy choice. And we also know that these are changes that are contributing in these communities and others to decreasing rates of childhood obesity. Because of these signs of progress, and because of the challenges that still remain, earlier this year, the Foundation committed an additional $500 million over the next 10 years to expand efforts to help all children grow up at a healthy weight. With this new commitment and drawing on the lessons we have learned over the past decade, with the help of many of you and researchers across the nation, we are focusing our work on 5 big bets. The first is to ensure that all children enter kindergarten at a healthy weight, because we know and we are learning more and more that preventing obesity early in life in those first 5 years is critical. Second, we are committed to making the healthy school environment the norm and not the exception across the United States. Third, our third is to focus on the elimination of the consumption of sugar-sweetened beverages among children 0 to 5. We can all agree that there's no reason for toddlers to be drinking sugary drinks. Water, breast milk are much better options, and that we need to be building healthy habits from day one. And I'll say that we're paying very close attention to the evidence on how best to do this, and are pushing ourselves and our partners to be innovative and creative here, because we know that this type of behavior change is not easy. The fourth is to make physical activity a part of the everyday experience for children and youth. And finally, we want to make healthy food and beverages the affordable, available, and desired choice in neighborhoods and communities. This issue of health affairs, focused as it is on food and health, points to the rationale for continuing to tackle the issue of childhood obesity and the essential focus on food in doing so. And to be honest, the articles also articulate the nature of the challenges inherent in this work, the complexity of the food system that needs to be considered, from farms to corner stores to schools to the broader market forces. And with that, the questions of where and how do we best intervene in those systems to make a difference? The behavior change that is part of this equation, and how we need to continue to experiment, understand, and learn from how changes in our policies, our environments, and our messages create the opportunities and incentives for change. This issue offers several takes on how the marketplace shapes people's decisions on food. Where do they buy their food? What impact can we have on what they buy? Can federal policy influence these factors and decisions? And this issue reminds us, as Alan pointed out, the multi-dimensions of food, the complexity of food, and the fact that we need to consider food in the broader socioeconomic model. That for many, many, low-income families, families that we are trying so hard to engage in this effort to address childhood obesity. Their decisions about food may be informed primarily by their decisions on housing and their ability to pay the rent each month. So less on is the food healthy or not, but can they afford to buy food for their family, as surfaced in the issues around food insecurity. That said, this issue offers us much encouragement. We are encouraged to see how U.S. diets have improved over the last 15 years and what improvements those have had, what impact those improvements have had on disease burden in our country. And the reinforcement that investing in prevention can yield us the results that matter to our health and save dollars. We need this type of evidence. The field needs this type of evidence in order to make progress on the real challenges. There are still many, many barriers to helping all children grow up in a culture of health and at a healthy weight. We must continue to examine these barriers, to ask what works, what doesn't, and why. And I'm looking forward to hearing the conversation today. Lastly, but certainly not least, I'm looking forward to hearing my colleague and co-author, Dr. Julie Willems VanDijk, talk about what we've learned from local efforts to improve access to healthy foods in some of the communities that have won the RWJF Culture of Health Prize. And this is timely, because just last week we were pleased to announce this year's winners. One of those winners was the Bronx. And the work that they are doing in the Bronx epitomizes the need and the range of efforts necessary to transform local food systems. As we spent time in the Bronx, it was clear that everyone knew someone with diabetes. In Fordham and Bronx Parks, nearly 15% of the population was diabetic, the highest rate in the city. They have the most unhealthy county in the state and have the highest adult obesity rate in the state at 28%. So you're thinking, why did they win the prize? They won the prize because of how they are taking action across multiple sectors to make sustainable changes that give everyone the opportunity to be healthy, drawing upon the evidence of what works, bringing together leaders from the health department, the health system, community, and resident organizations, agencies across the city to tackle the issues that their community is facing, the barriers to better health, and very specifically access to healthy food. Identifying and implementing solutions to increase the sale of healthy food in local corner stores, and making sure those sales are translating into consumption. So this is why we do this work, to inspire, to support, and to give local leaders who are committed to making this type of change and to creating the opportunity for healthy decisions, healthy living, a culture of health, the tools and the evidence they need to take action. The findings in this edition reaffirm the economic value, the moral imperative necessary to preventing childhood obesity and reshaping our food system so that we can ensure healthy choices are easier, available, and affordable. So I want to thank you for your contributions, and I look forward to the discussion today. Thank you.
Thank you, Abby. We now get to follow those terrific opening remarks with our first panel, which is the collection of papers in the volume that address the topic of obesity. We'll hear from Stephen Gortmaker, professor of the practice of health sociology at the Harvard Chan School of Public Health, where he also directs the school's Public Health Prevention Research Center. We'll hear from Claire Wang, Associate Professor of Health Policy and Management at Columbia University's Mailman School of Public Health, and Dong Wang, a Doctor of Science candidate in the Departments of Nutrition and Epidemiology at the Harvard Chan School of Public Health. So we'll begin with Steve Gortmaker.
How about the next one? One more. There you go. Good morning. I'm going to briefly review some results of the Choices Project that appeared in this month's Health Affairs. What can we do to reverse the increase in childhood obesity we've seen? Hundreds of approaches have been tried, but what is really effective? How much does it cost? What will the population impact be over the next decade if we implement an intervention? And how cost effective is it? Where do we get the best value for our money? Answering these questions has been our goal in the Choices Project over the last 7 years. And here's what our team has done. It's a big team. see all of our co-authors. We assembled a national stakeholder group, and together we selected the most important childhood obesity interventions to study, those being used, discussed, or those with some evidence. Among these, we chose the 7 studied here in this particular paper. We constructed logic models for each intervention. We conducted careful evidence reviews so we could clearly document the effects of these real interventions on BMI or energy balance. We reviewed lots of evidence across all of our interventions, more than 130,000 articles. We collected cost data for the interventions following standard costing protocols. We assessed their population reach as the intervention would be scaled nationally. And we created a micro simulation model. It's our belief that this is the best way to combine data on effect size, cost, and then to project the population impact and cost effectiveness over a 10-year period. The Choices microsimulation model is like a SimCity model. It uses lots of data on real people, census data, behavioral risk factor data, the American Community Survey, the National Survey of Children's Health. We use 5 different national longitudinal data sets, so we use real growth trajectories in our model, and medical expenditure panel survey results for healthcare costs. We assess the uncertainty in all these estimates, and I recommend our 65-page appendix if you want to see all the details. On to the results. And I have some copies of the basic part of the paper here if folks would like to see that, but you can also go to the website and download one for free. First, our funders, thank you. It includes the Robert Wood Johnson Foundation. And the first chart here shows the expected impact of the 7 different interventions on cases of childhood obesity prevented by the intervention in the year 2025. Now, those of you almost anywhere in this room probably can't read the chart very well, and I'm sorry. But one thing that's clear is if you look at the bottom bar, is that bariatric surgery has little impact on obesity prevalence. We chose this as kind of a benchmark because a lot of states, almost all states, Medicaid pay for this procedure. Why does it have little impact? Well, the average adolescent receiving the treatment has a BMI of 50. The intervention effect is big, as 13.5 BMI units, but that still leaves the children like with the BMI, or the adolescents with the BMI of 36. Also, of those eligible, those with a BMI of 40 or above, less than 2 in 1,000 receive the procedure. So this is an effective intervention, but it's really too little and too late to make any kind of a dent in the obesity epidemic, hence our interest in prevention. Beginning early in childhood when excess weight gain is small and the energy gap is small. I should note that the 95% uncertainty intervals, like which are not shown here, around the impact of improved school meals is large, and this is also the case for the menu labeling intervention, restaurant menu labeling. Nonetheless, all the interventions studied here, with the exceptions of bariatric surgery, make a significant impact in preventing excess weight gain and BMI gain and preventing excess cases of obesity. Our next slide perhaps is even more interesting because it takes cost into account and highlights the fact that 3 of these interventions are projected to save more for society than they cost to implement. This include the Smart Snacks intervention or implementation of nutrition standards for all foods and beverages sold in schools outside reimbursable school meals, modeled on the USDA regulations implemented under the Healthy Hunger Free Kids Act. This intervention, if implemented nationally, we project, is saving $4.56 for every dollar spent. This is an intervention that's pretty inexpensive and takes junk food out of schools. The second intervention, the excise tax of 1 cent per ounce on sugar-sweetened beverages, saves about $31 for every dollar spent, as well as big reductions in childhood obesity. The third one that is cost-saving is the elimination of the tax deductibility of advertising costs for television ads seen by children and adolescents for poor foods and beverages. Like right now, that's a tax deduction. The menu labeling intervention also has the potential to be cost savings. So to summarize our major findings, simulation modeling can provide useful projections of the future impact of policies, their cost, and cost effectiveness. Treatment of childhood obesity makes a small impact. Too little, too late. Preventive strategies are critically important, particularly those that are cost effective. Some interventions we've identified are save more than they cost to implement. Why are these not a focus of attention? The improvements in meal standards in the National School Lunch and Breakfast programs, as well as implementation of the first meaningful national standards for all other foods and beverages sold in schools, make the Healthy Hunger-Free Kids Act one of the most important national obesity prevention policy achievements in recent decades. We believe these cost-effectiveness metrics should become part of the conversation regarding obesity prevention initiatives. But one of the other points we emphasize is the fact that early prevention has so much potential because it takes place before much excess weight has been gained. It's also useful to note there are much larger healthcare cost savings to be had by simply focusing on adult policies. Most of the healthcare costs related to obesity take place among older adults. But if we want to truly reduce the level of obesity in the U.S., we must begin with childhood prevention. Thank you.
Good morning.
Morning.
My name is Claire Wang. I'm from Columbia University. The focus of this paper, Severe Obesity in Adults Cost State Medicaid Programs Nearly $8 billion in 2013, is on the cost of obesity, especially severe obesity's impact on healthcare costs in the United States. We also broke it down by state and by who are paying. It's a real honor to take part of this food and health issue and to be among so many excellent articles that really shifting the conversation that food is health. But of course, this article focused on obesity and its costs. This work is a group effort, and I thank my co-authors from 4 universities. This work is funded by the National Cancer Institute and by the JPB Foundation. So what motivates us to do this paper, and why now? Even though recent data suggested that obesity is leveling or even falling in some segment of the population, especially some encouraging news among young children, still we're seeing 1 in 3 American adults have obesity, which is approximately 81 million Americans. Of them, 33 million adults are considered severely obese. For someone who is 5'6", to have obesity, he or she needs to weigh more than 185 pounds and more than 216 pounds to be considered severely obese. Currently, about 14% of American adults have severe obesity. That's about 1 out of 7. We know that obesity, especially severe obesity, increases a person's risk for a long list of chronic health conditions, such as diabetes, heart disease and stroke, joint problems, and several forms of cancer. And obesity is largely preventable and, to a lesser extent, treatable. There has been some great work previously on estimating the cost burden of obesity, but the last published estimates were based on almost decade-old data. And none so far has separated out severe obesity, which has drawn more attention recently, as addressing severe obesity had to go beyond public health measures, as discussed earlier by Steve, and require clinical approaches. Moreover, as of this week, 31 states are expanding Medicaid. Regardless of this Medicaid expansion decision, there are intense debates on how to contain cost and which weight management services should be included in the benchmark plans. Our study aims to inform these debates. So very briefly, we used the National Survey Births Data 2013, which is the largest health survey in the world, with more than 400,000 telephone interviews each year. My colleagues at Harvard School of Public Health developed a novel statistical matching method to adjust for self-report bias for height and weight. This is something that was not done before in previous papers. We fit a two-part regression model to the nationally representative MEPS data to look at healthcare expenditure by BMI, combined with the fourth data source from Kaiser Family Foundation to reflect state-to-state variations in healthcare price. Together, they form the basis of our calculations. This is the table 1. I know it's very small, but I wanted to point out the first key findings. The first is having obesity increases medical cost, and much more so if a person's BMI is in the severe obesity range and for older adults. So starting from the bottom, in 2013, a person with severe obesity incurred $1,980 more medical costs each year compared to someone with normal weight. A person with class 1 or moderate obesity incurred $941 more than someone with normal weight. This is after adjusting for other demographic factors such as race and income. In other words, severe obesity adds 2 times more medical costs than moderate obesity does. And such increase becomes more pronounced in older adults and in women. Overall, about 40% of these added costs from obesity were paid for by Medicare and Medicaid. But if we only look at working age adults, severe obesity is more costly to employers. We had previous paper showing that workers with severe obesity are 40% more likely to call in sick. This underscores the role of employers in addressing obesity in the workplace wellness considerations. This is the exhibit 2 in the paper. It highlights that we estimated that the medical costs due to severe obesity amounts to $69 billion in 2013. That is 60% of the overall cost of obesity for moderate and severe obesity combined. This illustrates this finding by state, but if you're interested in the actual numbers for your state and the breakdown by payer, go to Appendix A11. I personally like this figure a little bit better in the appendix, pretty much conveying the same information. Across 50 states, severe obesity puts $8 billion, more dollars on state Medicaid programs. Depending on the size of the population, total healthcare cost, local healthcare cost, and eligibility criteria, we estimated that the expenditure associated with severe obesity ranged from $5 million in Wyoming to about $1.3 billion in California. Notice that the green line, which represents the prevalence of obesity in each state, is not necessarily a good indicator of which state are the ones paying more for obesity. States with large population with high healthcare costs, even if the prevalence isn't high, such as California and New York, needs to pay attention to how to mitigate the cost of obesity, particularly within their state Medicaid programs. This is also why the per capita cost of obesity map doesn't look like the obesity map put out by the CDC, even at the per capita basis. For example, West Virginia, Mississippi, and Tennessee had the highest obesity rates, yet did not rank high in the per capita obesity-related expenditures. This is primarily due to the relatively low cost of healthcare in those states. So what does it mean for healthcare policy? Based on the latest treatment guidelines, 65% of U.S. adults are eligible for weight management. 53% are eligible for drug treatment, and 15% are candidates for bariatric surgery. However, aside from bariatric surgery, there are still large coverage gaps for these clinical services in most states. Our study highlights the urgent need to ensure access to effective and cost-effective clinical interventions for severe obesity, especially for people in low-resource communities. Of course, concurrent with public health approaches to prevent obesity, especially in childhood. A final point. Many physicians may be more comfortable treating obesity-related chronic diseases such as hypertension and high cholesterol, rather than delivering dietary counseling and treatment for obesity. So there's a challenge and opportunity in enhancing clinical training and reimbursement if we wish to expand our capacity in treating obesity. I want to take the opportunity to again thank our funders and co-authors, as well as a list of awesome people who are graduate research assistants and field experts, without whom we'll never be able to do this. I'm happy to answer questions later. Thank you.
Good morning, everyone. I would like to thank Health Affairs for this great opportunity for us to present our paper here. And today I'm going to talk about the time trends in dietary quality in the United States from 1999 to 2012, and the impact of this change is in dietary quality on the disease burden. First, I would like to thank the co-authors of my paper for their fantastic contributions to this paper, and especially to corresponding author, Dr. Weil. He's also here to support my presentation. And okay, for this study, we have two research questions. First, we want to understand how the dietary quality in the past maybe more than 1 decade has changed over time in United States. So for this part, we just what we did is pulling out the dietary data from the 7 cycles of National Health and Nutrition Examination Surveys, and analyze the data and evaluate the dietary quality, use a dietary quality index, that is the alternate healthy eating index, to calculate the dietary quality for each individual. And this index was developed by the nutrition researchers at our department at Howard School of Public Health. The second research question is, because of this change in dietary quality, we really want to understand how this change in dietary quality has had some impact on at the population health level, that is the disease burden. So for this part, we just calculated the avoided chronic disease cases and premature deaths. For this part, a very important data basis is the biological effect of this dietary quality on different kinds of health outcomes. So we just pull out the biological effect of dietary quality from 2 long-running cohort study at Harvard, the Nurses Health Study and the Health Professional Follow-up Study. So here is our major findings. The purple line on this figure shows the time trends in our dietary quality score over the 14 years. We can see that the dietary quality score has increased modestly from 39.9 to 48.2. But I want to give a caveat here that if we compare the dietary quality score to the optimal level of the alternate healthy eating index, which is 110, the overall dietary quality in the United States population is still very poor. We still have a huge room for further implication. The second part is the disease burden calculation, which shows by the blue bars on this figure. If we each bar represents for the number of premature deaths has been prevented by the improvement in dietary quality for each 2-year cycle. If we sum up all these blue bars together, so over the 14 years, the improvements in dietary quality has prevented about 1.1 million premature deaths, which is pretty important findings from this study. And also for avoided chronic disease cases, we also saw pretty significant reduction in type 2 diabetes, a pretty significant reduction in cardiovascular disease cases, and also a few reduction in cancer cases. This is the second part of our major findings. So basically, we just broke down the overall dietary quality score into 11 different components of this dietary quality scores. So we don't have good news for each of these component dietary quality score. We do see pretty substantial increase in the component score for trans fat intake, which means the trans fat intake has been substantially reduced over the 14 years and almost eliminated from the food supply in the US. And we also saw a very important reduction in the soda and juice intake. But for other components, we only see very modest or even no improvement over time. And a very concerning trend is the sodium intake. That is, the sodium intake has been increasing over the 14 years. This increasing trend is very significant here. And we also break down our study population into different socioeconomic group and race ethnicity groups. So another very concerning trend is the gaps in dietary quality across different socioeconomic groups has been persisted over the 14 years and even become wider. We saw the poorest dietary quality among the African American populations, and this disparity in dietary quality between African American population and other race and ethnicity population has been largely explained by the difference in the socioeconomic status. So next, I would like to discuss about a little bit about the policy implications from our findings. First, we have seen that substantial reduction in the disease burden due to this improvement in dietary quality. So I think this finding really provide our further justification to prioritizing the healthy eating as a national priority to prevent chronic disease. So also because the dietary quality in U.S. population is very, very poor, so we actually have a very huge room to do some further works. The second is one of the most experience we gain from this, we have seen the substantial reduction in trans fat intake is the effectiveness and the efficiency of the legislature and the regulations. So these actions actually create a healthy eating environment to support consumers' healthy choices. The third part is we cannot expect trans fat intake to contribute more to the future dietary quality improvement because it has been almost eliminated from the current food supply. So that means we really need to take some more focused and more timely actions to address other components of healthy eating. The last part is we really need to adjust current federal nutrition and food assistance program to address these disparities in dietary quality. Thank you.
So as we tend to do at these sessions, I will ask a few questions and then open up to you as time permits. Steve, let me just start. I was struck as I read the paper, you compare cost, benefits to cost, and you talk about the cost of implementation, and I just hope for the audience you can clarify the elements of that. For example, when you look at something like a sugared beverage tax, what's included, what's not included when you see such a high cost-effectiveness ratio?
Sure. The cost of the intervention would be the cost of implementing within a state, and that typically involves administrative costs of hiring people to typically states have excise taxes already on things like fishing gear, or some states have SSB taxes, and it's just hiring more people. But there's some cost on the part of the industry to keep up with those taxes, administrative costs, and all those are included as part of the cost of the intervention. The cost savings parts comes in the sense that you have slower rises in BMI and thus rates of obesity, and because there's excess healthcare costs associated with obesity, as Claire pointed out in her paper.
And so the cost doesn't include the tax revenue. I just want to be clear.
Right, exactly. But totally separate from that, we point out that there's a lot of additional revenue, like $14 billion nationally, that you can use to pay for other obesity-related interventions.
Great, thank you. Claire, your paper looks at cost across all payers, but you did focus in on Medicaid, and I'm just wondering, given that, the cost burden is really a health cost burden, and yet based somewhat on Steve's paper and the literature in the field, when you expand coverage and when you pick up these costs with insurance, you're really picking up medical costs. This is not a big investment in prevention, right? So I'm just trying to match sort of the goal of prevention and reduced burden with the implications of expanding insurance coverage and whether those two come together.
Thanks for the question. It's a tough one. I think when we're thinking about obesity prevention and treatment, you could also think of it as a prevention by itself. It prevents the occurrence of something much more high cost, such as heart attacks, joint replacements, and so on. So there is a disease spectrum, and let alone premature death, for example. So I mentioned this previous paper on productivity. I think that's really important, and really to think about the population that will be most affected by the Medicaid expansion, relatively young and lower income population. To put these people in the system and have access to counseling treatment alongside the public health efforts, I think it's really important in thinking about overall cardiovascular health and overall well-being and productivity.
Great, thank you. Dong, your paper makes, you tell the trans fat story and then use it sort of as an example of what's possible. When I think about that, it's an example of elimination. Yep. Whereas a lot of what we want to do in the other areas is reduction, right? You talked about sodium and sugared beverage. So I just wonder if you could comment on how effectively we can use a model that came out of elimination for something where the strategy is more likely to be reduction.
Sure, thank you for this question. I think the point we make on this trans fat reduction is we really want to borrow maybe the underlying logic from this policy making procedure, that is to use some like the collective action to set the healthy eating choices as a default to support consumers' choices. That is the point we want to make. And so basically, not only on the reduction, on the elimination, we want to make some more expansion on this. For example, we can use tax. We can use subsidized to tax the packaged products in the chain market, in the chain restaurant, or food in the chain restaurant, and to use this revenue to subsidize some healthy food. We really want the future to be a more comprehensive solution for the whole dietary pattern, because from our study and from a lot of course, epidemiological study, dietary pattern is really evidence-based target for the policy making and a really actionable target for the policy making. Yeah.
Great, thank you. Let's take some questions. We have microphones and we're recording and videoing, so please wait for it to come, and go ahead and identify yourself as the microphone comes to you.
I'm Dr. Caroline Poplin. I'm a primary care physician. I was very impressed that you mentioned the trans fat example. The pushback from industry has been overwhelming, even to Michelle Obama's changes in school meals. They spend billions of dollars getting us to eat unhealthy foods with a lot of salt, a lot of sugar, a lot of fat. I was wondering if you're going to address in further papers how to get a handle on this huge pushback. I remember when I was practicing at Bethesda Naval Hospital, it was in a Republican administration, and they redid the food pyramid to make it unusable. So you need to have a strategy.
Let's hear from folks about how these policies are set in the context of the advocacy context.
Well, that's a big question, but I do think that one of the things that advocates can do now is just to really work to implement a couple of things already in place: the Healthy Hunger-Free Kids Act, smart snacks. I mean, there's good evidence that these are doing good, and let's keep them in place.
I think we have two kinds of things can do, at least from the academic community. First, we should keep generating the evidence to support the healthy eating and do the health education to the public. This is the first. Second part, we really need to have some like pilot program to be implemented, and as Steve and Claire has done, to do the cost effectiveness and to show the effectiveness, the effect of all these policy changes, the programs, and really to use this evidence as a very strong support to persuade the policymakers and also the public. That's my opinion.
It's here, and then we'll go here.
Thanks. I'm Jennifer Pomeranz, the College of Global Public Health at NYU. My question is for Claire. So my understanding is the federal government pays more in states where there's more need for Medicaid. So in those southern states you mentioned where you were saying that the states pay less for obesity, is the federal government picking up the slack there? And isn't that a policy issue that we should address? Maybe you did. Or...
Absolutely. And I think this is a changing dialogue as we speak. And this year, there's a lot of shifting climates on which state is expanding Medicaid eligibility. So there's definitely a shift between the federal government and the state on who is paying for the biggest chunk of the healthcare costs. But let's not forget there's also out-of-pocket payments for the states with large uninsured population. Nationwide, we're looking at about 20 to 30% of the obesity cost is paid by patients and their families. And that's substantial. So I think that is a really interesting question going forward as our next paper, hopefully, to see how expansion and changes in payer mix will change who is bearing the burden.
But can I just clarify, your Medicaid dollar, your estimate by payer was total Medicaid costs, not splitting out state federal. And so,
right.
So when you see it at by state, that really doesn't reflect the different match rates for different states.
That's a very fair point, yes.
Just want to be, since we're an evidence-based group here, I want to make sure we're getting the evidence out right. We have time for one or two more, depending on how pithy the questions and answers are.
Hi, my name is Angela Amico, and I'm with the Center for Science and the Public Interest. I was just wondering what level and type of sugar-sweetened beverage tax you included in your model for its impact on obesity.
It's a 1 cent per ounce. It's pretty much like what they have in Berkeley, California. Not that different from what they have now instituted nationwide in Mexico. That's a little lower level, but 1 cent per ounce.
It's about 20% higher in price.
Yeah.
Well, that qualifies as a short question with a short answer. Did I see someone here? And then.
Thanks, Walter Willett, Harvard School of Public Health, and to Dr. Wang. It's good to get an update on this, but I wonder if you've fully taken into account confounding by smoking and reverse causation in your estimates, which if you don't really do that, then you tend to underestimate the cost of obesity.
Yes, and we recognize that issue very much so. We didn't do, we control for smoking, and that's a short answer to that. Whether or not that's sufficient, I don't know. We did not address in terms of the premature death caused by smoking and whether or not that changes the dynamic. We also didn't do the dropping, we also don't have longitudinal data. So this is a cross-sectional analysis of BMI and other factors on their health care expenditure during that year. So I recognize the limitations, and I think more can be done. But I hope that we have better data to allow us to do that adjustment.
Okay, I'm going to thank our panelists for presenting the papers. Thank you all for engaging with the questions. We're going to move directly into our next panel, and then we'll have a break after. But we're going to turn to the topic of food security and insecurity. We'll be hearing presentations on two papers, one by Craig Gundersen, Soybean Industry Endowed Professor in Agricultural Strategy in the Department of Agricultural and Consumer Economics at the University of Illinois, and Executive Director of the National Soybean Research Laboratory. And we will hear from Hilary Seligman, an Associate Professor in Residence at the University of California, San Francisco, in the Departments of Medicine and Epidemiology and Biostatistics, and Director of the CDC's Nutrition and Obesity Policy Research and Evaluation Network. Where'd you go? There you are. You're ready to pounce. Take it away.
So do I forward it, or?
Yes, one forward. Sorry, two more.
Okay, great. Thank you all so very much for coming to this today. You all are very busy people, so I really appreciate your interest in this topic. I wanted to thank Health Affairs really a lot for inviting us to be a part of this. There's been so much work on obesity. We got to talk about food insecurity, and we're going to talk about it today. So I appreciate that this whole thing didn't just talk about obesity. So let me say that first. Second thing is that my co-author, Jim Zielak, is amazing. Unfortunately, you have me speaking instead of him. The other thing, though, is that Hilary is amazing. And there's some people whose work I always read, and hers is one of those. So I'm really looking forward to her presentation today. So let's begin. Food insecurity is, in my opinion, the leading public health nutrition-related issue in the United States today. This figure points out three key things about food insecurity. First, even during good economic times, during the early 2000s, those were good economic times, we had almost 30 million Americans who were in food insecure households. That's a problem. From 2007 to 2008, food insecurity rates increased by 30% over that time period, looking at the top figure. That's a huge increase. Okay? And this was a precursor to other things. If you want to know what's going to happen in the economy, look at food insecurity rates. The third thing I want to point out about this is despite the end of the Great Recession ended in 2009. Look what's happened to those rates. They have not declined. Something is going wrong in America. This is what points out that something is happening. You have to, every single presentation you have on low-income households should have something like this. It's not my figure. This is from the USDA's annual reports. I'm not asking you for, but you should be up there because this is a serious, serious problem. Now, before I turn to my next slide, it's great that you guys have these maps for health affairs. One thing you guys should have on the next issue is map the meal gap. Feeding America has this thing of food insecurity rates in all counties in the United States. Putting that on the next issue would be great, so we can really see the geographic distribution of food insecurity. I would have put that up, but I'm only given 4 slides. Okay, this is the main thing is there's serious, serious health consequences associated with food insecurity. A list of them is available there, and if anybody, well, you guys all have the article, you can read it. So, but I'm not going to present more details about it. So, 3 key things is not only are food insecure people more likely to have negative health outcomes, the effects are profound. For example, children who are food insecure are twice as likely to be in poor or fair health, controlling for other factors, as those who are food secure. Children who are food insecure are 1.4 times higher rates of asthma than food secure children. And for seniors, those who are food insecure seniors with ADL limitations are essentially equivalent to being 14 years older. The effects of food insecurity are profound. Let's talk about the importance of food insecurity health outcomes. Yes, we can talk about obesity. Yes, we can talk about other things, but don't forget about food insecurity. Okay. Now, what are the implications for healthcare professionals? We need to again recognize that there's increased recognition food insecurity leads to worse healthcare outcomes. As part of this is for those in the healthcare professions is consider asking about the food insecurity status of patients. There's a quick 2-item scale that can be used as part of the intake procedure. In fact, just last week or 2 weeks ago, I think it was, American Academy of Pediatrics urged more questions about this. And if people are food insecure, appropriately respond. Giving people quote-unquote prescriptions for food. There's been a lot of work done on this. Is that they can go to a food pantry at the hospital or somewhere else nearby. And of course, one of the top assistance program in the United States, SNAP. I'm going to talk about that momentarily. Get them into SNAP if they're eligible. The second thing is for healthcare professionals, if we reduce food insecurity, the reduction in healthcare costs are going to be huge. I mean, people talk about reducing obesity. We can have a discussion about what the extent of reductions will be there. But if you reduce food insecurity, you get huge reductions in healthcare costs. As an example is Weil Tarasek and I have a paper that came out in a Canadian Medical Association journal, which showed that using actual health records from people what they spent in Canada because they have a universal healthcare system is those who were in the most severe level of food insecurity had healthcare costs what's the figure on there? 121%. I was going to make this big. 121, then I have to look down. But 121% higher healthcare costs than those who are food secure. That's a big, big number, and we expect the same to be in the United States. If we want to reduce healthcare costs, let's talk about reducing food insecurity. And fortunately, we know how to reduce food insecurity in the United States. We have lots of solutions we can use. Most importantly is SNAP. Now, some, depending upon since I'm in Washington, D.C., I should say many government programs work. Some government programs don't work. SNAP is the quintessential example of an extraordinarily effective program. It sets out to reduce food insecurity, and it achieves that. The main goal of SNAP is to reduce food insecurity. How many other programs can say, we set out to do this, and we did it? And so, but the SNAP does that. We should all be praising SNAP, and we should all be turning to SNAP as an example of an effective program. Okay, so the next time anybody criticizes SNAP, you say, wait, stop. What was the goals of the program? Did it achieve those goals? And yes, it did. Now, so, okay, unfortunately, there's some people have different perspectives on this. There's two key groups of threats to SNAP. The first is that some have proposed block granting SNAP. Currently, SNAP is an entitlement program. Some have proposed to block grant it. The other thing is people have been proposing restrictions. These restrictions have taken two main forms. First, some people have said, let's impose restrictions on people that they have to work over a certain number of hours a week or something in order to get SNAP. That's the first restriction. The second restriction is these people who, the food police who want to restrict what people can purchase with SNAP benefits. They say, oh, you can purchase this, you can't purchase that. I've heard everything from banning Gatorade and Lipton iced tea consumption to this one group is proposing that everybody should have only purchase vegan things with SNAP. But anyway, there's all these restrictions that have been proposed on what people can eat. We don't propose those for other people. Why are we proposing this on poor people? I've never understood this. But anyway, some people propose these restrictions and have been proposing block grants. Now, I think these people are good. They're mainly it's almost all Republicans who are proposing restrictions and block grants. I mean, that's fine. Sometimes I vote Republican, but I disagree with them on this issue is because the Republicans have really been pushing these restrictions. So in your cocktail parties, when you're hanging out with your representatives or your senators, it's just start saying to them, SNAP works. SNAP works. It reduces food insecurity. It lowers health care costs in the United States. SNAP is a successful program. Don't mess with SNAP. And instead, we should be looking to SNAP as an example of how we construct other programs in the United States. Okay? That sounds great. 4, 3, 2, 1. I'm done. Okay, thank you.
Man, I am so excited to follow that. I thought I was going to have to introduce food insecurity, but I do not. So thank you for your kind words, Craig, and thank you for elevating this issue so that all of us, so that everybody understands the context of what we're working on. I want to start by thanking my collaborators at UC San Francisco and at Feeding America for all of the really hard work in doing this project, and also our funders, the Bristol Myers Squibb Foundation and their Together on Diabetes initiative. So food insecurity, in case you missed it in the last slide, in the last presentation, refers to the lack of adequate quality or quantity of food at all times for all household members, and is a very well-documented risk factor for poor diabetes control among people with diabetes. But few diabetes interventions, even those that explicitly target low-income populations, help address the lack of financial access to the relatively expensive foods that are the cornerstone of diabetes self-management. As the diabetes epidemic worsens, a growing number of community-based organizations and employers and payers are emerging as potential partners with health systems to help address diabetes outside of traditional healthcare settings, because we haven't been extremely successful in addressing diabetes, particularly in low-income populations, from within the narrow confines of the healthcare setting. So as sites for providing diabetes support, food banks have recently emerged as potential partners. And this is because food banks have a couple of key advantages over some of these other organizations. First, the system of food banks in the U.S. is enormous, and it reaches a very highly vulnerable population. Feeding America, the nation's largest hunger relief organization, includes a network of 200 food banks that reaches 46 million Americans every year with food. That's about 1 in 6 Americans. These predominantly food insecure clients are at very high risk of diabetes, and in particular its complications, which, as we learned in the last presentation, is a very strong driver of healthcare costs. Second, although food banks emerged as organizations to solve temporary emergency food problems and access to food, for many of the reasons that Craig just described to us, they now reach many of the same clients month after month, year after year. And that presents a real opportunity when you're talking about a chronic disease like diabetes. And finally, food is a cornerstone of effective diabetes self-management, and food banks have unique expertise in the procurement and distribution of food. So the goal of this study was to examine whether it was feasible and potentially effective to provide diabetes support at food pantries. And the intervention we implemented consisted of 4 components. The first was screening for diabetes and monitoring blood sugar control at the food pantry using a point-of-care test for hemoglobin A1C. A point-of-care test means we prick your finger while you're there in the line, and within 3 minutes we have not only your instantaneous blood sugar value, but also your hemoglobin A1C, which measures your average blood sugar over the previous 3 months and allows us to get a good idea of whether or not you might have a diagnosis of diabetes. So that was the first component. The second was referring clients to primary care if they had diabetes and were not receiving care. The third was to provide diabetes self-management support and education from the food pantry itself, so a place where clients were already going every month to receive food, many cases every month. And the fourth was to provide people with diabetes appropriate food that was both shelf stable and perishable products that was distributed once to twice monthly. We had 3 food banks participating in the project: the Redwood Empire Food Bank in Sonoma County, California, the Mid-Ohio Food Bank in Ohio, and the Corpus Christi Food Bank in Texas. And these food banks reached clients through their partner food pantries, which distributed food directly to clients in need. In all, we enrolled 687 participants. They were very diverse, more than 50% Latino, more than 80% reported being food insecure, and more than 60% had a high school education or less. They had an average body mass index of 34, which puts them in the obese range. So a very vulnerable group of participants. This is the result of the pre-post analysis, and I'm going to focus here on the 396 participants who entered the study with a hemoglobin A1C greater than 7.5%, meaning that their diabetes control was suboptimal when they entered the study. I will say, though, that if you look at all the participants, the 687, our results are virtually identical. Average hemoglobin A1C fell from, among those with an A1C elevated at baseline, from 9.52% to 9.04%, which is a highly statistically significant result. And the percentage of clients with very poorly controlled diabetes, or an A1C greater than 9%, fell from 52 to 43% of the patients in our population. We also observed improvements in daily servings of fruits and vegetables, in self-efficacy, in the emotional burden of having diabetes or diabetes distress, in medication adherence, and in having to make trade-offs between paying for food and paying for your medications, or having to make trade-offs between paying for food and paying for your diabetes supplies. These are all really important secondary outcomes because they are mechanisms by which we think food insecurity predisposes individuals with diabetes to poor control. So this is the first study of which we are aware to evaluate the effectiveness of harnessing the really large infrastructure of the charitable food system to provide health promotion in the form of diabetes support. It's a promising model because the capacity of the charitable food system for reaching vulnerable communities and for accessing and distributing healthy foods is really unique. It also provides a framework for food pantries to develop the infrastructure to provide healthy foods, which is not trivial. The infrastructure that you need to do this includes the cost and complexity of distributing perishable food items, which is challenging. Finally, if this model is supported in more rigorously controlled studies, it suggests additional potential benefit for population health because the food distributed from food pantries reaches not just an individual, but the entire household. And these entire households are at risk for chronic disease. And finally, similar models may prove useful not only for diabetes, but for other diet-sensitive chronic conditions, including obesity, prediabetes, hypertension, and congestive heart failure. Thank you.
Well, in addition to now having 2 new bumper stickers to put on my car, don't mess with Snap, and something is going wrong in America, I do want to follow up. I actually sort of have a question I think that touches both of you. I started by wondering, based, Craig, in part on your presentation, does the focus on obesity, with all respect to our funder, make it harder to get attention to food insecurity? But then when I want to try to take that one step further and ask, is part of the story of the food police and the desire to sort of really get inside and tell people what to eat in some sense related to concerns that if all we do is solve food insecurity or address food insecurity, we may be contributing to another problem that's getting a lot of attention, obesity? So how do we find the middle here, I guess, is my question for both of you. How do we not make this insecurity on one end, obesity on the other, but healthy eating and sufficient access to food as a joint goal? Craig, you want?
So, I mean, there definitely is, just to be clear, is that in moving people from food insecurity to food security, we also see people's health going up in terms of their health they need. You have better nutrient intakes, or they're better over many different dimensions. So generally when people move from food insecure to food secure, they're able to afford better diets and they purchase better food. So in terms of that issue about moving, I don't think that addressing food insecurity will lead to any changes in obesity rates. And if anything, for example, if we address food insecurity by increases in income and maybe increases in SNAP benefits, we'll probably see obesity rates fall, because we know as incomes increase, obesity rates fall. But back to this narrow question about some of these food police type of activities is, in some ways, is they tend to stigmatize poor people. The food police so often picks on poor people. I mean, they say poor people should eat this, they shouldn't eat this, they should eat this, they should, in ways that we would never, ever say to non-poor people. I used to work for the federal government. Nobody told me how to spend my paycheck. Why do we think it's fine to tell poor people how they should spend their SNAP benefits? I mean, give them advice, give them information, just like you give me information, but don't impose restrictions. That's patronizing and condescending to poor people, and that's what I'm against. So I think that that's why we have to be careful about proposals that will stigmatize and demean poor people in the United States.
Yes, and I will add to that. There are 3 reasons why I think we always have to keep food insecurity and obesity in the same bucket. One is that calorie for calorie, the cheapest foods in the US are nutrient-poor, calorically dense foods that predispose people to obesity and diabetes. And to the people who argue with that, and there is some controversy, I firmly believe it, but there is some controversy, there is no doubt that the perception is that that the only foods that you can afford with a very low budget are calorie-dense foods. The second, people who anticipate having a food shortage in the near future change their eating behaviors in a way that predisposes them to obesity and diabetes. And this includes things like hoarding food, binging behaviors, etc. And the third is about the most stressful thing you can do to a household is make it food insecure. And we know, particularly among women, that this extreme levels of stress predisposes people to obesity, not just regular obesity, but the visceral obesity that is very hormonally active and predisposes you to diabetes. So we have to keep these in the same bucket, and we have to understand when we talk about food insecurity in a globalized food market like we have in the US, we're not only talking about lack of access to calories, we're talking about huge amounts of access to very cheap, nutritionally poor, empty calories. So it's a malnutrition problem as much or more than a lack of calorie problem in many food insecure households.
Thank you. Yes.
Hi, Hilary. Vivica Kraak from Virginia Tech. Related to that last point, on your conclusion slide, I don't see anything about establishing nutrition standards for donations to food pantries. Can you address that point, please?
Yeah. This is a very complicated question because food banks were established to meet emergency food needs in which any calorie was a good calorie. And that makes sense in the short term for a food insecure household. It doesn't make sense with the way that food insecurity is currently experienced in the US. So there is a history in food banking, and there are very strong efforts to develop systems that will help that will allow food banks to be part of a nutrition solution, and those are ongoing. We are not where we want to be, I think, as a charitable food system. There's a long way to go, but there is increasing recognition that because we are such a strong part of the food system, we have to reach higher and do better. And that's where this intervention came in, is trying to create some of the systems in which food banks can be part of a community solution rather than part of a community problem.
Let's get up here. two in here, and then we'll probably be approaching a break. We'll see.
Hi, I'm Tammy Calise from John Snow Inc., and we just completed a food assessment with the Health Trust in Santa Clara County and found that 45% of income-eligible folks were income-eligible in Santa Clara County, but yet 58% were enrolled, and for reasons for complex paperwork and lack of access to SNAP offices. And I'm wondering if you have suggestions on how to help get more people enrolled that are certainly eligible.
Do you want to answer?
There is a lot of variability in SNAP enrollment across the in states across the U.S. California has one of the lowest rates of SNAP enrollment, partially related to the fact that the SNAP system in California is county-based, so it's essentially 48 different SNAP programs in California. This is a huge problem in California in particular, and one that provides extreme opportunity for improving health outcomes.
And just to follow up, I agree, is that you think of SNAP as a way of improving health, and I think that has to be emphasized a lot. There's a lot of things being done we have to reduce transaction costs, as Hilary said, to make it easier for people. We also have to figure out ways to reduce the stigma associated with SNAP, and imposing restrictions would increase the stigma. So in other words, is that we have to figure out ways that more people get at SNAP, and reducing stigma is one of them. Reducing transaction costs is also one of them.
We're getting a few people here. I'll go here, and then Donna, and I think at that point we'll probably be at a break. So the gentleman back, yes.
Todd Post with Bread for the World. I appreciate both your presentations and the great work that you both do. Craig, you talked about SNAP. SNAP is administered through USDA, and the food banks get much of their food through USDA. We're here at a healthcare conference. We tend to put food insecurity into, it's a USDA issue, it's an issue of food availability. We deal with obesity over in healthcare. The CDC is piloting all these efforts. And I agree totally with you, Craig, with what you said at the beginning, that I think it is, food insecurity is a huge public health problem. What can we do through healthcare policy to integrate more attention on food insecurity so that we help to elevate it so that the rest of the country, including the people in healthcare, see it as a public healthcare crisis?
So since Hilary's a doctor, she should respond. But let me first quickly respond, is just really hammering home this point that if we think about, the people talk about the cost associated with SNAP, and it's an expensive program, it's a big program, that's why it's successful, but we should think about the benefits associated with that across feeding people. Of course, that's a benefit in and of itself, but to the reductions in healthcare costs due to SNAP should be factored in any discussion when we talk about medical care. But now we'll turn it over to the doctor.
I think that's a conversation that we need to be serious about. There are a number of proposals that have been put forward that I will mention. One is to do universal screening, as the American Academy of Pediatrics is now recommending for children. The second is the use of community benefits funds through ACA rules for nonprofit hospitals to use these funds to directly address nutritional needs within the community. This has a lot of promise, not a lot of activity yet, but we look forward to seeing how that looks in the future. The third opportunity here, I think, is really integrating more closely our programs like SNAP with people, for people who have chronic disease or who are at risk of chronic disease. And I think that is an opportunity that has not been adequately explored yet. And the fourth is, I would say that food insecure people, 1 in 7 Americans is food insecure. They are not only arriving at federally qualified health centers and safety net hospitals. These people are in every single health system in the United States. And until physicians and the healthcare community is able to really observe and understand these patients are our patients, and we are spending a lot of time and effort trying to help people to better control their obesity and their diabetes and their high blood pressure, and we don't understand why we can't do a better job of it. Until we recognize the critical role that food insecurity is playing, we have a really uphill battle to climb.
Let's do one quick question with some quick answers, and we need to move to a break.
Hilary, if I'm understanding this correctly, maybe something that you weren't able to measure directly is the fact that your success had to do with the fact that you had clients who trusted you, who knew that you understood their circumstances, had compassion towards them, and you were giving them information that was specific to their situation so that they could change their behaviors. And how important do you think that is, even if offhand?
Thank you so much for bringing that up. This is a key advantage that food pantries have, is food pantries are in your neighborhood. They're often open hours that are convenient for you. Volunteers in food pantries are very, very often people who live in the community and who are clients of the food pantries themselves, so they're peers. It feels very different, I think, to a client to get diabetes support from their food pantry than it does from, you know, the academic clinic on the hill where I work. It's lovely, but it's a very different environment. I think that's really very important. But I will also mention that the neighborhood embeddedness and the trust that people have with their food pantry is critical. Thank you.
So I think we could continue this for a while, but we can't. To keep us on a 12:30 end time for this session, let's take a 10-minute break. We'll come back with a couple more panels. Please thank our presenters. Okay, we're going to move to a session on health systems and how they function, how they could function better. We're going to hear from David Wallinga, Senior Health Officer at the National Resources Defense Council in San Francisco, who founded and directed the Healthy Food Action, a national network. We're going to hear from Roni Neff, Assistant Professor at the Johns Hopkins Bloomberg School of Public Health's Department of Environmental Health Sciences, jointly appointed with the Department of Health Policy and Management. Vivica Kraak, Assistant Professor of Food and Nutrition Policy in the Department of Human Nutrition, Foods, and Exercise at Virginia Tech in Blacksburg, Virginia, and Julie Willems VanDijk, Associate Scientist, Co-Director of the County Health Rankings and Roadmaps Program, which you've heard about today, a collaboration between the Robert Wood Johnson Foundation, University of Wisconsin Population Health Institute. Without delay, let me turn it over to David. Oops, we have Roni's slides first. Let's see. Oh no, I'm sorry, you're right. I knew this. That was a test.
Great. So clicker forward. Okay. Good morning. So I'm happy to be up here with Roni Neff, one of my co-authors on this commentary, and really she did the lion's share of the lifting, so the paper wouldn't have gotten done without her. So she was already speaking and was kind enough to have me speak on this analysis. So as was appropriate for a set of co-authors that included me, who's been an advocate around healthy food and agriculture for 20 years, and an academic from Johns Hopkins and a former deputy secretary of agriculture, we were looking in a very broad way about the intersection of agriculture and the science that now shows how essential it is in shaping public health. But there's so much to agriculture. It's such a huge topic. And it has so many dimensions. We spent a lot of time trying to devise a graphic to try to help people get their hands around it. Unfortunately, the graphic doesn't really lend itself very well to a paper journal, and especially a shorter article. So actually that graphic I just showed is going to be on the Center for a Livable Future website, and you can look at it more there. But the material's still there in Exhibit 2, just in a little different form. So let me just say that the food system is not just agriculture. That's a piece of it, but it's really all the activities and processes that go into producing, then processing, distributing, consuming food. And there's all the interactions between those things. So as complicated and huge as agriculture is as a topic, the food system is even bigger. But despite that, it is a worthwhile approach to take this systems approach to looking at issues of food policy. Why? Because the health benefits of taking that systems approach are more and more recognized. And despite that, despite this increasing science and a body of academics who are doing research on it and publications and thinking about it, it's still not really part of the mainstream of thinking around health policy, but it should be. There's 4 major benefits from taking the systems approach. One it helped shift the policy attention from this over-focus on just individuals to really public health, to looking upstream at what the broader social, environmental, and other interests, determinants are of the health of the population, as well as the individuals in the population. Two, as I said, these are incredibly complex issues. And the way we have been historically trying to address food policy really did not lend itself well to that complexity, and especially the interactions and intersections of the different factors in the food system. A systems approach does a much better job of that. Three, it gives you more insights into fresh strategies, how to innovate both in around policy, as well as anticipate unintended consequences. And four, it introduces a time component. None of these things are static, and yet much of our thinking has been very static and ignored longer-term impacts, feedback loops, things that are built into systems modeling, not only about food systems, but other kinds of natural-based systems. So that's the why systems. So back to this graphic. Again, we just focused on food production, and it's appropriate because we're about halfway through the program, and production of food is only about halfway through the issue, this issue of health affairs. But it's important because, you know, if we don't produce the food, we're not going to have it to eat at the end of the pipeline. We identified 4 different pathways that can describe how agriculture ultimately impacts on health. And you'll see them here. It's not only the nature and the quantity and quality of the food itself, but its community impacts, both really direct and then somewhat more indirect, like climate change or water quantity or soil fertility. And then finally, and perhaps most overlooked, the impacts on workers. And then we, in Exhibit 2, which is kind of the guts of the paper in many respects, we say that these impacts can either be positive or negative, depending on the kinds of decisions that are made in setting up that agricultural system. And so it's a little confusing because you get into this trick of, you know, are we thinking about the system we would like to have in place or the one that we actually have in place now? But I won't go through these, but just to describe some of them, you can read them in more detail later. So for example, just to take out a few cases, workers, there's some evidence now that workers and veterinarians and others around livestock production are having much higher prevalence of colonization with methicillin-resistant Staph aureus. But this is never mentioned when one thinks about the health of the food supply. So to look at this a little different way, we had 3 brief case studies and tried to use this framework around systems to analyze to what degree we've successfully engaged people from the agriculture and health sector to work together around thinking about and devising policy in that space. So the first was the growth of farm-to-school programs. And the 4 criteria we looked to look at those are up on top. And in this particular case, we found that the potential of a systems approach really was realized. There was a lot of engagement of the different sectors with each other. We saw this huge increase of over 400% in farm-to-school programs from 2006 to 2012. And there's limited but encouraging studies showing that the estimate across all these studies, the average estimate of an increase in fruit and vegetable consumption was from about 1 to 1.3 servings per day. So a net positive. The second case study was around the dietary guidelines and sustainability. And you've probably read a fair amount about this. What you can say is that there was really vigorous debate and raised awareness around the intersection of these two things. With the comments to the Dietary Guidelines Advisory Committee over the last version of these guidelines going up by about 25 times. So from roughly 1,100 comments to nearly 30,000. And we had a fairly transparent process with the advisory committee to consider all this. But as you know, last month, the Secretaries of Agriculture and Health indicated that the current version of the dietary guidelines will not reflect sustainability issues. And then lastly, antibiotic use in animal agriculture. And here the promise really hasn't been realized. There's some greater awareness of how important the 70% of medically important drugs that are used not in people but in agriculture are used. But there's really a lot of doubt still about how this is going to translate at the federal policy level. And the question I would leave you with is, can we really address this other huge crisis in public health without addressing also this 70% of medically important antibiotics that are used in food animal production? Thank you.
Good morning, and thank you for the opportunity to talk. Thank you to Health Affairs for the opportunity to join this panel. I've really enjoyed the other presentations, and I'm getting a lot from it. And I'd also like to thank my co-authors, Rebecca Cantor and Stephanie van de Vijveer. We waste 30% of the global food supply, and in the United States, we waste 40% of our supply. And that's a huge problem for a lot of reasons, including environmental reasons. But I'm here to talk about this from a public health perspective, and this is probably the first paper that's made that linkage directly. And when people hear these large numbers, they say, how can this be, and how does that happen? And so the answer is that it's very complex, and there's a lot of different things going on. A piece of this is also unavoidable, but some of the major things going on are that globally, in lower and middle income countries, the losses occur typically more at the beginning of the food chain due to lack of good roads, lack of refrigeration, lack of good storage, weather. And then in higher income countries, it's primarily at the end of the food chain with things like consumers and restaurants and retailers and the conscious and unconscious decisions that are made. Something historic happened about a month ago. The United States committed to cutting food waste in half by 2030. That's a big commitment. The United Nations has similarly committed on a worldwide level, and other countries have joined in this as well. And public health is part of the solution. So my colleagues and I developed an analysis looking at a set of policy and program interventions that make this linkage with public health. And for most of them, there's a clear win from making the linkage. But for a few of them, when we address the waste of food, we could actually cause detriment to public health. And so these are strong reasons for partnering with those working on food waste, both to advance our shared wins as well as to open conversations about alternate strategies or deciding among conflicting priorities. I'm going to share a few brief examples, primarily from high-income countries. And let's start with food security. So I'm not going to review these numbers because we just heard about them previously, but I will say that wasted food is a big part of the solution. Not a big part. It's a significant part of the solution. But distribution is going to remain a concern, both in terms of the logistics as well as in terms of equity issues. And the strategy that I'd like to discuss here is food recovery. And currently there's a tremendous amount of innovation going on in the food recovery space. And this can be encouraged with policy strategies like tax incentives for crop donation. Generally speaking, this is a win-win. But as started to be alluded to in the discussion earlier, there are a few important areas where it's not necessarily. And one of them is the issue that the donations have to cater not only to the needs of the donors, but also to the needs of the recipients, whether that's in terms of logistics or whether it's in terms of the nutritional quality of the food. And food banks more and more are working to build in, for example, relationships with farms where they bring in fresh produce. And some food pantries are setting limits on the food that they'll accept. The second challenge with food recovery is that, let's face it, giving food to people isn't the way to get to the root causes of food insecurity.
We should be looking at building incomes and things like that. And so when we focus a lot of attention on the shiny object of food recovery, there is a risk of diverting that attention. And similarly, the goal would be to prevent overproduction and this surplus from the start. And when we are incentivizing people to donate surplus, that could get in the way of focusing where we need to. The second public health area that ties into food waste that I want to talk about is food safety. And there's essentially a dynamic tension between food safety and food waste. When we have food, we don't know if it's good or not. We can either throw it out or we can eat it and take a risk. And food safety, from other work that I've done, is in fact the #1 reason that US consumers give for discarding food. And so the goal is we want to prevent the food from becoming unsafe in the first place. And we also want to help people understand how to make wise decisions about what food is safe and what isn't. We're public health people. We don't want to have people taking unnecessary risks. So the strategy that I'll talk about here is date labeling policy. And there's a lot of evidence that consumers are widely misunderstanding the date labels like sell by and use by. And as a result, they're both throwing out a lot of excess food based on their perception that these labels are telling them about safety, as well as they may be trusting those labels to tell them that the food is safe when it hasn't been stored properly. So we need an improved and clear policy on date labeling in this country. And the final area I want to talk about where food waste intersects with public health is nutrition. So I want to highlight 3 shared risk factors for overnutrition and waste. And the first one is oversupply. So we have about double the amount of calories in the US food supply that people need to eat. And so this oversupply contributes to a low valuation of food throughout the food chain. The second is that while many in industry are working to develop solutions where they can profit from reducing food waste, the overall piece is that there's a benefit to industry from us buying too much. And finally, when we don't plan ahead, when we buy too much, when we have portion sizes that are overly large, when there's too much food, we can either eat it or we can throw it away. So either one isn't necessarily optimal. And of course, the third option would be to preserve it, but we don't do a lot of that in this country yet. So the strategy example that I want to talk about here is supporting secondary markets for so-called ugly produce. And this could be an apple that's an unusual shape, or it's too small, or it has a scab on it, for example. That's good, nutritious food that when you go to the supermarket, you don't see it. Why not? Because much of it gets thrown out before it gets to us. It doesn't get given to anybody. So there's really important opportunities to both process that food as well as to sell it at a discount. And people will pay for this produce when it's sold at a discount. And policies can support and incentivize these kind of markets. So in conclusion, as the United States and as the United Nations and others work towards these 50% food waste reduction goals, a public health food systems approach is an important part of the solution. Thank you.
I'd like to thank Alan just for having this briefing and also including our paper in your special issue. Where's the advance button? Oh, okay. Green. Green. Oh, green. That makes sense. So I'm going to talk about actually a question that came up earlier, and I'm glad that the pediatrician in the audience is still here, about whether and how to engage with the private sector, because there are a lot of private sector actors. I'm going to focus my comments on guiding principles in a decision-making framework for stakeholders who want to work together across sectors to pursue healthy food environments. I would also like to thank my co-author, Mary Story, who heads the Healthy Eating Research Office for the Robert Wood Johnson Foundation. She's at Duke University, who helped with this paper, as well as Health Canada that provided funding for some of the formative work related to this paper. So about 2/3 to 3/4 of the calories that Americans get in our food supply come from ready-to-eat processed convenience foods, which means that the food industry has to be part of the solution. And it's very attractive, oftentimes, when an NGO, a public interest NGO or civil society group, or a government organization may be approached by a food or beverage manufacturer to say, we've got $1 million to do this, we have $2 million to do this, what should we do? And so in working with a variety of groups and reviewing what sort of principles and engagement strategies are out there, we came up actually with 6 very easy to remember principles as well as decision-making framework steps. This is important because we're not saying you have to engage, but given the current political environment where voluntary engagement with the food and the beverage industry is the preferred strategy by policymakers as opposed to legislation and regulation, it's important for organizations to have a thoughtful process that they follow to decide whether or how to engage. And so what we did is developed a framework with 6 steps. Earlier this year, the American Society for Nutrition developed a 12 principles, which are really tough to remember. So the first step actually is public interest in innovation. And that's the principle that goes with, okay, you've got some money, but let's back up. Let's clarify the goals and objectives for the public-private partnership and how it will benefit public health and the public good before we go further. The second step is actually related to the guiding principle of partnership diversity and compatibilities. And that involves each partner, whether it's a public interest NGO or a government organization, as well as a company, to conduct due diligence for the compatibilities of the partnership, the benefits, as well as the drawbacks and the risks. So even before you get to the partnership phase, you've put some thought into it. The third principles are pragmatic and anticipatory planning, which really helps the partners design a plan to manage tensions, and there will be tensions, potential biases, and actual or perceived conflicts of interest even before you get to the partnership, so think it through before the organizations decide to engage. The fourth level of the principles is really, once you decide you're going to partner through a public-private partnership or an alliance or some sort of coalition, you need to really think through the governance structure and the stewardship of the resources and to develop a formal agreement that will clarify the terms of engagement. And then the accountability for the outputs and outcomes is the fifth principle and step, and the final is the communication and whether you're going to continue that partnership or close it. So we actually took this 6-step principles and partnership decision-making framework and looked at 4 national partnerships in the U.S. That we actually tested this framework to see how well they've done. And so we looked at the Partnership for Healthier America's obesity prevention pledges from 2010 to 2015. We looked at the Healthy Weight Commitment Foundation's calorie reduction pledge that they initiated in 2010 to 2015, the National Salt Reduction Initiative that's based out of New York City, as well as Walmart and Humana Vitality's Healthy Food Retail Incentives Initiative. And what we found, and we were just using information in the public domain, we didn't have access to proprietary information, is that we looked at some of the outputs that occurred over the last 5 years. For the Partnership for Healthier America and the Healthy Weight Commitment Foundation, we did find that these national engagements did show some level of accountability and effectiveness over the years that they've engaged. The partnership brokered 150 public commitments across 5 pledge areas for diet and physical activity to prevent obesity among children, and they've got several progress reports to document that. The Healthy Weight Commitment Foundation made a pledge in 2010 to reduce 1.5 trillion calories out of the U.S. food supply, and they tripled that by 2013. But the thing about that partnership is that the Robert Wood Johnson Foundation came forward proactively from the very beginning to say, we will put up money for an external evaluation. And they gave funding to colleagues at UNC Chapel Hill that actually did a very extensive examination of what the Healthy Weight Commitment Foundation had achieved. And we talk about that in the paper. It was 16 Healthy Weight Commitment Foundation food and beverage manufacturers who actually did do what they said that they would do in 2010. The National Salt Reduction Initiatives, their sodium reduction pledges, they really don't have the funding, and they haven't really provided the disclosure and the transparency about their governance and how they're moving forward. And we really do need FDA's leadership to come forth and help out with voluntary engagement to reduce salt in the U.S. food supply. And then with Walmart and Humana Vitality, there was very little to depend on, although some of the papers that will be presented later do talk about the improvement improvements in the food retail sector. So in conclusion, the paper does talk about future directions, which I'm not going to cover now because I'm in my last 60 seconds. What I'd like to emphasize is that the 6 guiding principles and the decision-making steps that I described earlier, they can help facilitate various stakeholders' decisions about whether and how to engage. Not that you have to, but whether and how. And if you decide not to, at least you've gone through a thoughtful process to decide not to engage with a food or beverage manufacturer or restaurant or a food retailer to address obesity and diet-related NCDs. Also, we need independent evaluations for public-private partnerships. There's a lot of controversy still around those to build credibility and public trust in voluntary engagement strategies to promote healthy food environments. And partnerships can be evaluated, and some of the areas are their overall process, which we do need more information about how the Partnership for Healthy America was successful, how Healthy Way Commitment was successful. So we need to do that, synergy, accountability, and effectiveness in achieving the partners' goals. Thanks.
Good morning. Thank you to Health Affairs for this opportunity, and to my co-authors, Bridget Catlin, Abby Cofsky, and Carrie Carroll for the work we did together on this paper. We're going to go from national partnership to local partnership, as our paper focuses on the real-life experiences of communities who received the RWJF Culture of Health Prize in 2013 and 2014. The really wonderful thing and encouraging thing, as I've the 9th speaker and have listened to prior speakers, is these communities are reflecting many of the themes we've heard today. They're implementing policies that Steve talked about. They are talking about food insecurity. They're thinking about how they work with agriculture. They're reflecting many of those partnership principles that Vivica just mentioned. So these communities are selected as prize winners based on these 6 criteria. So defining health broadly, not just clinical care, but also social and economic factors and healthy environments, a long-term approach that focuses on policy, an equitable approach, a collective approach, a focus on using resources wisely, and measuring and sharing progress. While the communities are not required to discuss food-related strategies as part of their application, all 12 of these communities did have a substantive focus on food. So what we did as part of this study was review their applications and conduct follow-up interviews with 9 of the 12 communities to learn about what they were doing in regard to food and how they were implementing their strategies. As a result, we identified 37 different food-related strategies being deployed in these communities. And then we compared those strategies to the evidence reviews and ratings in What Works for Health, a database that's available on the countyhealthrankings.org website that provides evidence reviews and 6 levels of ratings, as displayed on this slide, that are based on the quantity, quality, and findings of relevant research. What Works for Health includes over 340 strategies that address all of the health factors in the County Health Rankings model, and as you'll see in this table, 42 of those strategies directly relate to food. The table details the evidence of the 42 strategies in the broader database and then the 37 strategies in the communities. The most common strategies that we found in the 12 communities were farmers markets, community gardens, and school-based nutrition education programs. When we turned to how communities were implementing these strategies, we discovered many strengths and challenges within the communities. A few highlights include the following. These communities were working across sectors, and their partners ranged from healthcare providers to food pantry operators to public health to school staff to farmers to community residents and many others. This collective approach was really critical because they were implementing a multi-pronged strategy to address healthy food environments within their community. In fact, the median number of strategies implemented in each community was 11 different strategies. Community preferences are the primary driver of how communities select which food strategies that they're going to work on. We were surprised that none of the communities used evidence as a primary driver. However, several of the community members told us that once community strategies were selected, they were able to turn to other evidence-based resources such as the community guide or What Works for Health to further customize the strategies. And others noted that, intervention strategies driven by funding programs such as the community transformation grants from CDC or program standards such as nutrition standards in the school nutrition programs help support the implementation of evidence-informed approaches. When we looked at challenges, poverty was the most often mentioned challenge to these communities in implementing strategies to enhance the food environment. And communities address this through a macro approach, through macro approaches such as working on living wage laws, and programmatic approaches such as this picture from Willems in West Virginia, where a community garden was sited across the street from low-income housing, which both provided easy access to healthier foods, and the residents were able to sell the produce, the surplus produce, at a farmer's market to enhance their income. And then evaluation also presents challenges, especially when striving for shared measures across sectors. The farmers want sales data, the food pantry staff want hunger reduction data, and the healthcare providers want behavior change and health status. So as we looked at lessons to take away, we focused on the need for building capacity for collaborative leadership. Our community members told us that change happens at the speed of trust. And this type of collaborative leadership is a very different type of leadership, and thus we need further development in those skills. To advance, spread, and scale, communities need multiple reinforcing strategies. They need to start where they're comfortable, but also expand breadth and depth. And despite community leaders not using evidence as a primary source for strategy selection, they still implemented many strategies that had a strong evidence base. So we encourage communities to use resources such as What Works for Health and the Community Guide, and we encourage policymakers to embed evidence-informed strategies in funding opportunities and program standards to further accelerate the uptake. And then finally, this issue of evaluation. It's important to support academic community partnerships and other evaluation support so that we can assure that these efforts are implemented in a way that produces the desired effects. And also, since communities are deploying innovative and yet untested strategies, it's critically important that we assist them with evaluation so that we both learn more about what works next for future generations and can disseminate those strategies to others. So thank you again for this opportunity to be with you.
I have one question I just want to sort of toss out to all of you for a reaction. You all talked about systems in very different contexts. One of the questioners earlier mentioned the fragmentation of responsibility in food. So a very simple question. What's the biggest step you could recommend to a public or private actor to take to promote a more systems-based or systematic approach to addressing the issues that you raised in your presentation? David, do you want to give us a start?
Well, I'll give an example. I am from Minnesota, and the health department, using a CTG grant, embarked on a multi-year process there to write a food charter, which was really a food system charter, a blueprint for the kind of food system they wanted. And it was all based on participation of people across the entire breadth of the state. and discipline. So they really invested in something that often doesn't get invested in, long-term collaboration and dialogue. And through that, I actually think it was a very good document, but it reflected a lot of very good thinking among these groups and among people who normally didn't talk to each other.
I was actually going to say something very similar, but I think that there is a need to create these spaces and to get a systems approach and to build relationships across discipline takes time, it takes building relationships, it takes learning each other's languages. And often the participants that we want to be in the room don't have funding themselves to be there. And so there needs to be funding for people to be there, as well as for research at these interdisciplinary places, which often also may be a real need.
I agree with the interdisciplinary approach that Roni mentioned. Also, there's some very useful frameworks that groups, particularly internationally, have developed to help us think through the whole complexity of the system. So I'd just like to bring up one from Australia and New Zealand, Informas framework, because I've worked with Professor Boyd Swinburne and Stephanie, who's one of the co-authors on Roni's paper. And the way to think about it, there's 7 different areas of the food environment that the actions of public sector stakeholders and private sector stakeholders both influence. And there's food composition, which is the reformulation, such as the Healthy Weight Commitment Foundation example I gave. There's food labeling, food promotion and marketing, particularly to children, food provision, particularly in public sector settings like hospitals and government work sites, healthy food retail, food pricing, and food trade and investment. And how does that impact the population diet, our physiological metabolic risk factors, and our health outcomes?
And when I look to local communities to answer that question, Alan, I recall a statement shared with me by Karen DeSalvo when she was the commissioner of the New Orleans Health Department. And she said, people don't live in sectors. People live in real communities. And so I think part of the answer to your question echoes my colleagues, which is we must maximize the integration of these efforts together, because food obviously affects poverty and income and health and school performance. And so the more we can look at how we integrate these efforts and integrate the measurement of the efforts, I think the better our systems will function.
Great. Yes, sir.
Hello, Jeff Byers, Healthcare Dive. I was interested in where do you see hospitals and health systems executives coming into play with this integration?
Who wants to take that?
Well, I'll start. I think a previous speaker mentioned the importance of the community benefit work, and I think that's a great opportunity to make meaningful community health needs assessments that are translated into integrated action within the community. I think as payment reform moves more and more to paying for health versus illness, the economic incentive will be there for healthcare practitioners and hospital leaders in a new and revived way.
I'd like to also add to that, since I focused on partnerships, one of the very tricky areas is transactional partnerships. When you have a company, a large manufacturer that says, we have $5 million we want to give you, and I think just recently on change.org there was some sort of petition going around. Krispy Kreme Donuts gave a large sum of money to a healthcare center, I think that was in North Carolina, but their name was associated with it. So I would first advise that groups really need to think carefully, particularly around healthcare, about corporate sponsorship and whether and how they're going to engage and when it's appropriate not to engage, or what sort of activities they decide they're going to support. The second part is unrelated to my first, and Michael Hamm from the University of Michigan just came 2 days ago at Virginia Tech, and he talked a lot in Michigan, some really innovative work they're doing, where they're getting commitments from the hospital sector to support 20-30% of whatever food that's locally produced that they will purchase. So it's really nice, innovative work where they're supporting sustainable food system work, but it's across the hospitals in the state, and I think other states can replicate that.
Great. And I would build on that to say when we're talking about waste, when you think about an institution the size of a hospital, the amount of food that gets wasted can be staggering. And there's a lot that can be done at an institutional level, whether it's in the cafeterias or whether it's in patient care, and it's both prevention of waste and actually like doing better at maybe asking patients what they want, as well as taking the waste that exists and putting it into compost.
I have a little different take. You know, we've spent decades investing in an infrastructure for treating disease, and we have to really be careful not to kind of look for ways to use the existing infrastructure and forget about what the infrastructure would look like if we were starting with a national priority to invest in health. Because I don't know that in 40 or 50 years, hospitals that are now constructed are going to look like the best place to have a farmer's market, especially if the hospital's out in the outskirts or it's not where people live. So to really do a good job, I think we got to be brave enough to start with the question of how do we create a community food environment that serves the needs of the people where they live, you know, and using mechanisms that engage those people.
Great. We have two more panels, so I'm going to thank our speakers here and ask the next group to come up. To keep us as close to time as possible, I'll go ahead and begin with the introductions, as we're being joined by Jennifer Pomeranz, a clinical assistant professor in the College of Global Public Health at New York University. Brian Elbel, Associate Professor of Population Health and Health Policy at the NYU School of Medicine, where he heads the section on health choice policy and evaluation in the Department of Population Health. And Linda Harelick, Director of Operations and Communications at Child Obesity 180 at Tufts University Friedman School. Jennifer has a plane to catch, and so she goes first, and questions go to her first, but we are going to get her on her plane, I promise. I'll turn it over first to you. Don't rush. You got plenty of time.
Okay. I have to teach a class. Okay. So thank you so much, Health Affairs. I'm thrilled to be here and to present my work. I will be talking about outstanding issues with respect to the First Amendment related to food labeling disclosure requirements. And so I'm a public health lawyer, and food labels are a form of commercial speech protected by the First Amendment. So any type of government requirement to disclose information on food label has to be within the bounds of the First Amendment. And so the first thing that happens is a court will look to determine if a government is restricting or compelling speech. And my talk and paper is about the compulsion of speech, disclosure requirements. And I'll be talking about this in the terms of real and also potential legal challenges to the government requiring speech disclosures. Many courts actually have had trouble with this, the question even if it's a disclosure or restriction. And in my appendix, I set forth all the court cases that have trouble, and you can see that there are outstanding issues. The Supreme Court case of Zauderer is the case that controls disclosure requirements. And this was a case about finding that an attorney advertisement was deceptive without the required disclosure. The Supreme Court often finds attorney advertisements to be particularly confusing to the public. So unfortunately, the law doesn't relate as well to other cases, but it's being applied in the food label world. So in order for a food label to be a disclosure requirement to be constitutional, it must be factual and uncontroversial. Unfortunately, the Supreme Court does not tell us what the word uncontroversial means. So circuit courts have been kind of equating it with factual. It can't be subjective. It can't be opinion-based. It must be factual. The Supreme Court said that the government's interests must be reasonably related to the disclosure requirement. In other constitutional contexts, they usually describe the government interest. In an equal context, they usually say it has to be legitimate. Here, they don't say anything, and so that leaves it up to we don't know. Another thing is that in the court case, the actual Zotero case, it says that an advertiser's rights are adequately protected as long as the disclosure requirement is related to the prevention of deception. So any entity that is required to disclose has been arguing that the only government interest that can work is the prevention of deception. Thankfully, the circuit courts have overwhelmingly found that that's not the case, because if you think about all the disclosure requirements, allergens, the nutrition facts panel, ingredient lists, it's hard to say that all of these are to prevent consumer deception. But in the food context, it is good that we can say they're often to prevent consumer confusion, which is another recognized interest. But again, these are outstanding issues. And the final is that the court said that it cannot be unjustified or unduly burdensome. And again, it didn't tell us what unjustified meant. It does say that evidence wasn't required in the Zotero case itself, but frankly, that's not really true when it comes down to the circuit courts. The government is expected to amass evidence for its actions, and it should continue to do so. And because this was an attorney advertising case, it doesn't, again, translate. So evidence is often required for government action. I looked at 3 different types of food labels. The first is the FDA's requirement to include an added sugar disclosure on the nutrition facts panel. This was a clear-cut disclosure requirement. There really are no constitutional issues for this one, and it was used to compare then the other 2. The second I looked at was the state of California safety warning for sugary beverages. This is a bill that's been proposed a few times in California. It has yet to pass. It talks about the health issues with drinking sugary beverages. There are 2 concerns. The first is that the American Beverage Association constantly says that there is no link between sugary beverages and obesity and diabetes. We know that's not the case. However, they have funded studies, and there are studies out there that do disagree with the conclusion that we've all reached that this is a perfectly legitimate label. Luckily, the courts have looked past these types of evidence in the tobacco cases especially, and we would argue that this is not controversial, but the state might be having to argue this, and this is the reason to amass evidence for its action. The second issue is the actual wording of the state of California safety warning. Because the California does put its state name in it, this is good. If it doesn't, the industry could actually argue that it doesn't agree that it's a safety warning. So it's very important that the government requiring the disclosure put its name into the disclosure requiring, similar to the Surgeon General's original warning, in order to avoid other types of challenges. The final label I looked at is the Vermont law that requires the disclosure of genetically engineered food, and it has other requirements, but I only focused on the disclosure requirement. There are 2 main issues. Right now, Vermont is embroiled in a lawsuit. They've been sued over this disclosure requirement and restrictions. And there are 2 main issues. The first is that the plaintiffs argued that this is very controversial. The court correctly said just because it's been enacted in the backbone of having a controversy doesn't make it controversial speech. It's a factual issue whether the food is genetically engineered or not. But the second part of the lawsuit is a little less clear. The plaintiff said that that it is unjustified, and the legislator said that they enacted the law because of consumer concern about genetic engineering. There's court cases that say that consumer curiosity alone is not enough. It's unclear whether this distinction will matter, and we'll see this play out in the courts. So my recommendations include the government entity should disclose itself in the warning. Government should gather evidence to support their disclosures, set forth legitimate government interests, consider how a label might be used to diffuse consumer deception or confusion, and keep that in and put that into your legislative record. And also consider interests that have been upheld in prior cases, informed decision making related to health, safety, and environmental, not simply consumer curiosity. So thank you so much.
Thank you very much. Continuing on with NYU here, I want to thank my co-authors, Courtney Abrams, Jonathan Cantor, and Alejandro Torres, and our funders, which included RWJ, the New York State Health Foundation, and the NIH. So a little bit of background, right? So I think you can make the argument that when you really think about large-scale public policies that are meant to influence obesity in recent years, you really zone in on calorie labeling as being a really important one of those. And I'm from New York, and so in New York City, we were one of the first to implement one of these policies in 2008. Soon in quotes to be part of federal law, and schedule right now December 2016. December 2016. And a lot of these controlled studies don't show a huge effect on calories purchased, but these studies tend to be pretty limited in terms of the time period they look at. The longest one being sort of a year and a half. And so, we wanted to kind of move beyond that, and we wanted to look much longer. And so we looked in New York City about 5 to 6 years after labeling had been implemented there. So our study thus far, we believe, is the longest one that's been published that actually has a comparison group that tries to set out some of these secular changes. We did data collection at 5 different time periods. Our first study, also published in Health Affairs in 2009, looked at the 2008 before and after period there and really tried to zone in on it. Was there immediate effect? And we went back and actually collected data in 2013-14 at 3 separate time periods separated by about 6 months to try to get to this longer term impact. And what we're looking for here, and I'm going to show you a little bit of data on, is are there any changes in using labels as being one important outcome here that we get from consumer survey data? Any changes in consumers seeing and using labels, and also the nutrition content of the calories purchased was the other main outcome that we looked at here, as well as a whole bunch of other nutrition related outcomes. So how do we get this data? We really have research assistants hang outside fast food restaurants and get people's receipts as they leave. And we pay them for it. We do a short survey just to confirm what it is that they ordered and to really zone in on the number of calories purchased, where we also ask them some of these questions. And the data that I'm going to show you today come from almost 7,700 fast food consumers, focusing on 4 chains. The bigger sort of food chains in New York City: McDonald's, Burger King, KFC, and Wendy's. And again, we're collecting data from New York City, which implemented labeling in 2008, as compared to a couple other cities in New Jersey, Jersey City, and Newark that didn't implement calorie labeling. So that's the sort of overall structure of our design. So what do you see, right? So you see here how the first thing we're looking at is here, how did consumers noticing and reporting using this information change over time? And that really top line there is before labeling and after labeling, right? In terms of seeing this information. You see it goes up from some number less than 20% upwards to about 50% in New York City where labeling was implemented. So you do see this really big increase in the percentage of consumers that see labeling. The orange bar below that is our comparison group, which didn't implement calorie labeling as rule. And so you see that's really flat. So you definitely see this increase. It sustains over time as compared to the baseline, although declining a little bit. So you do see a lessened percentage of people who report that they saw the information over time in 2013-14 compared to our 2008 period. The green bar below that is the percentage of people who said, yes, I saw it and I used it to purchase fewer calories. So again, an increase here that remains sustained over baseline, but obviously a much lower number. And by 2014, only about kind of 9% of folks who report seeing this information and using it to influence their fast food purchases. So I think the story here is definite increase in percentage of people who see and use this information over time, although at a decreasing rate, and really not an overwhelming number necessarily when you're at the 2014 period, although a meaningful percentage probably. What we didn't see is any change in calories purchased over time as a result of labeling. So you see, going back into our 2008 period, we're sort of in the upper 700s to the low 800s potentially over time. So no real change, no statistically significant changes here at all in terms of calories purchased that we can attribute to labeling at all. So what does this mean, right? So I think we have an increasing amount of evidence that labeling, at least at fast food restaurants, and I think that's an important distinction we'll talk more about in a second, is probably not enough to curb obesity by itself. I don't think anyone really assumed that it would be, and we're going to have to think about other policy approaches, a lot of which you've heard about today, I think in a very important way. I think we're going to need to think a lot more about, could we do anything to make these labels more effective? I don't think the USDA is jumping up and down to try to change this very complicated law to actually administer, but I think that's an important question that we need some more work on. And I think the other thing to point out is that while we studied an important slice here in terms of fast food places, lots of other places that these labels are going to be implemented as well. Sit-down family chains, other sorts of locations, depending on how exactly this regulation plays out. And so I think that it's really important to think about some of these other policies and be mindful of the fact that a lot of our work really zones in on this one place in terms of fast food. So that's it.
Good morning. I am delighted to be here representing my co-authors for this work that we have done. And this research was funded by the Robert Wood Johnson Foundation and the JPB Foundation. And so I want to thank them for their support. We evaluated patterns and orders of children's meals following healthy changes made to a children's menu, and more recently followed up 1 and 2 years after the initial assessment. With 1/3 of children in the U.S. overweight or obese, every sector has to play a role in reversing the trend of childhood obesity, including restaurants. Recent data indicates that just over 1/3 of children eat fast food on any given day. Typical restaurant fare is high in calories, and children consume more calories when they eat out than when they eat at home. Additionally, children who eat at restaurants compared to those who do not consume more fat and added sugars and less fruits and vegetables. But does it have to be this way? Some research suggests that taste preferences are established in childhood. Yet there is also evidence that children's palates are malleable with experience and repeated exposure. In April of 2012, the Silver Diner, a full-service family restaurant chain, made healthy changes to its children's menu by offering more healthy meals and automatically bundling all entrees with healthy side dishes that included strawberries, mixed vegetables, or a salad. Additionally, French fries and fountain drinks were removed from the menu but could be substituted at no extra charge. Healthy children's meals and side dishes met nutritional standards set by the National Restaurant Association's Kids Live Well program. Previously, we analyzed and published aggregate data from children's meals before and shortly after these healthy menu changes. We demonstrated notable shifts in healthier ordering patterns. In the new study, we analyzed orders of children's items more than 1 and 2 years after the menu changes went into effect to assess the extent to which these healthy changes were sustained. In total, more than 650,000 children's orders were analyzed across the 13 standard outlets of the restaurant chain. Data from each period included the total number of each type of children's entree, bundled side dish, beverage, and dessert ordered. Each item was coded as healthy or unhealthy based on its designation as meeting the Kids Live Well criteria. Lastly, we examined the restaurant's total annual revenue. The changes that we observed in our previously published study are shown here. Orders of healthier children's entrees increased from 3% to nearly 50%. Healthy side dishes bundled with entrees increased from 38% to just shy of 75%. Orders of French fries declined to 22%, and soda declined 5 percentage points to just under 30% of orders. But could these changes be maintained? Here's where I think I need a drum roll. Thank you. The current study shows that the overarching healthy changes in orders of children's items were sustained over the next 2 years, with continued improvements in some cases and small fluctuations in others. Orders of healthy entrees remained above 40%, and 3/4 of children's orders came with a healthy side dish and 3/4 with a healthy beverage. Additionally, total annual revenue for the restaurant grew by 5.3%, exceeding the average revenue growth in the family dining segment. This work demonstrates that if healthy choices are easy to make, positive behavior can be long-lasting. These findings, in combination with past research, suggest a number of avenues that have the potential to make the healthy choice the easy choice and shift cultural norms in restaurants, making healthy options more prevalent and prominent, making healthy options more automatic, making healthy changes that are already on trend and gaining momentum. For example, as a first step, making changes to side dishes and beverages may be the most acceptable to children and more financially viable and economically feasible and operationally feasible to the restaurant. Although additional research is needed to test the extent to which the current findings generalize to other restaurants, the growing evidence around the promise of healthier children's meals offers the potential to shift cultural norms and redefine what we think of a kid-friendly meal. Thank you.
So Jennifer, I'll start with you both because you may want to run out the door, but also you went first. And one of the themes in all of these papers is sort of the effectiveness of approaches that have some intuitive appeal, but when we first start them out, all we have is the intuition, and we're at the sort of evidence-building stage. And I would apply that, Jennifer, to your discussion, although it's from the legal side of product labeling. It seems to me implicit in your paper is the notion that this is a valuable approach to communicate information to consumers. And I just wondered if, to the degree to which you feel confident that that element of labeling or mandatory speech has enough of an evidence base that we should be pushing the legal issues here, or if really this is more a legal inquiry somewhat distinct from our knowledge base with regard to the effectiveness of the approach.
Thank you. It's different depending on what label you're talking about. The Nutrition Facts Panel, we know, is read mostly by women and higher educated people or people with health problems or whose doctors have told them to read it. But from a social justice standpoint, I think that we have a right to know what's in our food, and so I believe in labeling even just from that standpoint. The warning labels have not been, I don't know the evidence if they've been tested somewhere. I don't know about that. But if you think about it, a warning label could even just alert, have a parent who's about to hand their child a beverage with a warning label might think twice because now the child can read that they're being handed a warning labeled product. So there are so many ways to test this. It needs to be done. But I believe that we have a right to the information about our food, so that really supports the labeling.
Before I bring the others in, just because of your time constraint, are there any questions particularly directed at Jennifer? Let me get two in, and then you'll stay as long as you can, but let's get these two.
I'm Kim Zabarak from the American Academy of Nursing, and my question is, what is the likelihood of the courts, you think, upholding and having it pass muster for a different presentation of the labels? For example, instead of listing 36 grams of sugar, perhaps a pilot test showing literally 9 teaspoonfuls of sugar on the label that more people would be able to relate to than it's simply saying 36 grams.
Yes, as long as it's a factual disclosure requirement, the court would uphold that. Since that's a factually based disclosure, that's legally fine.
Okay.
So I wanted to briefly touch on the GMO labeling issue because I think it's fundamentally different than the issue regarding labeling the soda cans, because as you mentioned, there's evidence regarding the negative impacts of sugar-sweetened beverages. We can have a debate about that, but there's really no evidence that GMOs lead are problematic in terms of people's health. And so I think it's fundamentally different, and so I just wanted to point that out. And there's also identifying what's in a GMO is really, really hard. It raises food costs, which has a disproportionate impact on low-income consumers. So I'd be a little bit careful with the GMO stuff.
But you didn't read my paper because I didn't actually support GMO labeling in it. I am just doing the legal analysis, and I actually don't think that this is going to win in Vermont. Unfortunately, I like Vermont's government very much, but I don't think it's going to win in the courts.
Let me open it up, and so I have to begin with an editorial comment. Linda, I think in your future analysis you need a dummy variable for the quality of the desserts. As a parent of children who like the Silver Diner, I have to tell you the milkshakes are really good, and so it doesn't matter how good the rest of the menu is, they're going to walk out with milkshakes. But what I really want to do is ask the two of you to sort of comment a little bit and reflect on the lessons from the other paper, because one's focused on fast food, one's focused on sit down, and each of you sort of alluded to the unique nature of both the clientele and the setting, and so I just would like you both to contextualize by thinking about the other paper. number.
Yeah, and ours focused on putting a number on a board, and theirs focused on changing a menu. And I think that's the really big one here. You know, I think in Linda's case, you could sort of go in and you actually had to work a little harder to get the thing that was going to be less healthy. And I think that's sort of the making the healthier choice, the easier choices language you hear a lot here. And I think that's a perfect example of it, where you could go in and try to order what you always do, and if you did, it was going to be pushing you towards this other direction. So I think that's one really important distinction to make here.
Yeah, absolutely. I mean, we've done focus groups with low-income moms and talking to them about calories and menu labeling and what would change. And, you know, bottom line, like, no one's doing a math exercise when they walk into a food restaurant, except maybe potentially, you know, high-income women. So I think it's really important that we look at what's really working to change behavior, and definitely, you know, making it more normative, making those healthy entrees more normative, and making them more automatic. Clearly, in this case, worked really well, and I think it's something that could be adopted across, you know, many different segments of the restaurant industry.
Great. If the gentleman over here still has a question, we can get you in. If let's.
Yeah, David Wallinga, NRDC. Jennifer, you seem to make a distinction or prefigure a distinction that court's going to try to make between a label that signals curiosity versus concern or justifiable concern. Can you expound a little bit more about, like, how would the court determine that?
So the circuit courts have said that consumer curiosity alone isn't enough to support a government interest, and this was in a food labeling case in New York, and then another one with the most recent, the disclosures about the cool labeling, country of origin labeling. They were saying if it's just to satisfy consumer curiosity, that's not enough. But the interests that have been upheld are when it's about consumer decision making, informed consumer decision making in order to support healthy choices or environmental concerns that are, so for example, mercury disclosure requirements in Vermont were upheld as saying that if you know that there's mercury in your product, then you know how to dispose of the mercury containing product properly. So this information can be used to better the environment. Same thing with food. You can use the information to better your health if you know the added sugar quantity in the products. But when it's just curiosity, the courts have not said. The problem with this area of law is that there is so much confusion around the law that, you know, that's a subjective word too. What's consumer curiosity? I don't know. In Vermont, it could be upheld as a consumer curiosity or not. It's very unclear. That's why the government needs to kind of stick to really safer measures. The Zauderer test is supposed to be easy to satisfy, but with all the complexity and unclarity, we don't know where it's going to go because companies are constantly challenging the government.
Yeah. I'm trying to.
This is a question for Brian. Your study has a pretty small sample of pre-intervention data. I have like 155 in the comparison group, 327 in the intervention group. And the likely effect of menu labeling is going to be small.
Yep.
So what were you powered to detect? What kind of a difference could you have detected?
We could have detected around a 50-calorie difference, right? So clearly not. You know, some of your studies showed, you know, maybe an 8-calorie effect. We were definitely not powered to see some of those, right? And so that's why I think the result has to be here. You know, like labeling on its own isn't going to do it, but you know, maybe combined with lots of other things. So I think it's going to be an important thing to think about how we could get better data, and that's really probably only going to come from the food industry itself, you know, to try to detect some of these very small effects that by themselves won't be meaningful, but in a cumulative way could.
We'll take a last question from Claire, and then we'll move to our final panel, which is great, so please stay for that.
A quick comment disguised as a question. In the past year or so, all the giant fast food restaurants are changing their kids' meal in terms of what is the default beverage and the side. So I'm hoping that Brian will be able to look into that and see if that's causing a difference. But the question is, So is it fair to say now, our colleague Sarah Bleich's work is that menu labeling is largely a supply-side intervention. Is that still the case, and what's the latest evidence on that one?
Yeah, and Sarah, who couldn't be here today, does have a paper on the same issue that tries to look at that, where they try to get some sense of that. They let's look at places that voluntarily label and see if they have different calories, and find that they do. Do we know yet, and they're very clear on this, that we can say this is caused by labeling? No, but it does make you want to look a little more in that direction. I think to the point of Linda's paper, if we can see some of these supply side changes, where because the information's there, the restaurant industry then reformulates food or puts lower calories on the menu, that again is a very nice public health win. I don't know that we exactly can say that yet, but we definitely need to look more in that direction.
Okay, thank you to our panel, and we'll pull up our last group. Everything in moderation, including being the moderator. Okay, let's. We have a final panel that looks at food purchase, food shopping. And we're going to hear from Dalia Stern, who's now at the National Institute of Public Health in Mexico, but is presenting work done as a doctoral student at the University of North Carolina, Chapel Hill. Laura Cobb at Union North America as a senior technical advisor on the Bloomberg Philanthropies funded Data for Health Initiative, and Tamara Dubowitz, senior policy researcher at the RAND Corporation and affiliated faculty of the Pardee RAND Graduate School. I will get out of the way, advance the slides, and let you take us from here.
Thank you, and I want to thank Health Affairs for this opportunity. So on behalf of my co-authors, I'll be presenting this paper entitled U.S. Household Food Shopping Patterns, Dynamic Shifts Since 2000 and Socioeconomic Predictors. So a major gap in the food access literature for low-income and racial ethnic minorities is a focus on physical access to food stores and the lack of data on where people actually shop for food. So studies have shown that race minorities and low-income groups have limited physical access to grocery stores or supermarkets, and they have more access to convenience stores, for example. However, there's limited evidence about which type of stores are used by these groups, as well as how the stores are combined. Therefore, this paper was focused on two different research questions. So the first one is, where are U.S. households shopping for food, and did food shopping change over time? And then what socioeconomic group characteristics are associated with the recent food shopping patterns? So we used the US HomeScan consumer panel data set. Here we have households' food purchases from 2000 to 2012. For our first research question, we used cluster analysis to group households by their food shopping patterns, and we did this for 2000, 2003, 06, 09, and 012. And these shopping patterns were based on the amount or proportion of volume of households' packaged food purchases by store type. And then for our second research question, we used multinomial logistic regression to determine what socioeconomic characteristics were associated with food shopping patterns, and this was only done in 2012. So here you can see the results for 2012. On the x-axis, we have the three different shopping patterns or clusters that we found, and on the y-axis, we have the proportion of volume from households' packaged food purchases. Each bar here represents a different type of store. So as you can see, our first shopping pattern or cluster was characterized by households purchasing food primarily at grocery chains, and 50% of households were classified under this shopping pattern. Then our second cluster was characterized by households primarily shopping at mass merchandisers. This type of stores are like Walmart or Super Target. And 23% of the households were characterized under this shopping pattern. And then the last one, you see that households are actually purchasing foods at different type of stores, both the combination of small and large stores, and 27% of households were classified under this cluster. So Oh, and before I talk about the income and race ethnic differences, we found the exact same clusters over time. There was a little bit of a difference about the proportion of volume that was purchased in each store, but basically households tend to combine the same type of stores when they shop for food. So in terms of our income and race ethnicity as predictors of food shopping patterns in 2012, we saw that among low and middle income households, there were no race ethnic differences in the probability of shopping primarily at grocery stores. In other words, every race ethnic group in the different income levels shopped for food at grocery stores. And among low-income households, non-Hispanic blacks were less likely than non-Hispanic whites to do their shopping primarily at mass merchandise stores. So what were the key findings and conclusions of this study? Basically, what we see is that people shop for food at a mix of stores instead of only choosing one particular store to do their shopping. And overall, we also saw that households get no more than 10 or 15% of their food and beverage purchases from convenience stores. And they do get more from grocery stores and other larger type of stores. Therefore, this might suggest that issues other than access to grocery stores might be important to improve the diets of these households. And in terms of policy, we believe that policy strategies focusing only on supermarkets or grocery stores might be ignoring other places where US households are making their food purchases. So we strongly suggest that these varied shopping patterns be considered in future studies and policy initiatives. And I'm also here on behalf of Barry Popkin's research group, and I'll be presenting Dr. Lindsay Smith-Daly's paper entitled Gains Made by Walmart's Healthier Food Initiative Mirror Pre-Existing Trends. So what was the rationale for this study? So more and more food retailers are implementing initiatives to improve the healthfulness of food purchases. And Walmart has been one of them. And in 2012, 80% of households actually shopped at Walmart. So we can see that it's a really big player. Walmart formally announced its Healthy Food Initiative in 2011. And it was comprised of a front of a package label, price cuts, and product reformulations. So the question of this study was whether Walmart's HFI, or Healthier Food Initiative, improved the nutrient profile of purchases made there. So the authors used the same data set, the HomeScan panel data set, which is a longitudinal data set. They used information from 2000 to 2013. The authors used fixed effect models with inverse probability weighting to control for the fact that people choose to shop at Walmart for a variety of reasons. And their analysis compared the observed nutrient profile of purchases after the initiative to the counterfactual. So by counterfactual here, what they mean is what they would have expected to occur based on pre-initiative trends if this HFI was not enacted. So here, as you can see, on the x-axis, we have the years, and on the y-axis, we have the energy density. And you can see three different lines. So the orange one is what was actually observed. The blue line is the best fit counterfactual based on the pre-HFI trend if we take 2007 as the date where this HFI was initiated. And the purple line is the same counterfactual, but if we take 2011 as the start of the HFI. So basically, this might be a little bit complicated, and I'm going to do my best at explaining this. So what you can see here is that if we assume that the start date of the HFI occurred in 2011, which is in orange, is less than what we would have expected based on the prior on the prior trend of the initiative. And here you can see the counterfactual in 2011, which is the purple line. However, Walmart's marketing materials indicate an earlier start of the HFI, and some of them are dated to 2007. Therefore, the authors also tested this counterfactual. And using 2007 as a start date of the HFI, after the initiative, energy density declined even less than what we would have expected. And again, we're comparing here the blue line to the orange line. So the reason of this is because the majority of the declines occurred between 2000 and 2007. Therefore, what we find is that there appears to be no effect of the HFI on the energy density of food purchases. Similar results were found for sodium, total sugar, and saturated fat densities. The authors did find an increase in fruit and vegetable purchases, declines in grape-based desserts, candy, and savory snacks, and they also saw declines in sugary beverages, but these were small. So what were the key findings and conclusions of this study? Overall, they saw that the nutrient profile of purchases made at Walmart did improve from 2000 to 2013. But again, these improvements did not appear to be attributed to the HFI. And finally, more systematic policy approaches coupled with shifts in food preferences will be needed to encourage healthier food choices. Thank you.
Hi, everyone. Thanks so much to Health Affairs for the opportunity to present. And I also wanted to just say that this is part of the work that I did as part of my dissertation at Johns Hopkins School of Public Health. And I want to thank all my co-authors, many of whom were my dissertation advisors and really critical to this work. So, as has been noted by the previous speaker, there is not equal access to healthy food in the United States. Researchers and USDA reports, as well as other nonprofits, have found that lower income communities and communities of color in the United States have lower access to healthy foods. Additionally, to date, there have been few really comprehensive and effective policy solutions. I think the next speaker is going to talk about one of the most successful areas, which has been bringing supermarkets into underserved communities. But there's been very little sort of policy focus on actually increasing the healthy food availability of existing small stores and communities. There's been a lot of programmatic activity, but it's mostly been voluntary and small in scale. So in 2009, the WIC program, which is a supplemental nutrition program targeted at women, infants, and children, changed their policies to better align the packages of food that they offered, that they subsidized, with the dietary guidelines. And as part of that, and critical to this study, they also changed what stores, the 46,000 stores nationwide that participate in WIC, what they were required to stock in their stores. And importantly, a number of studies have looked at that in the sort of first year after implementation and have found significant increases in healthy food availability in these stores. So our study took advantage of two existing surveys that were done in Baltimore City in 2006 and 2012. And if you look at the map, you can see it's a map of Baltimore City, and the dots represent the 118 stores that were surveyed at both time points. And each store was given a score from 0 to 18 about the healthy food availability, with 18 representing higher healthy food availability. And what we found over the course of the 6 years was that the mean healthy food availability score rose from about 7.1 to 8.3, which was a significant 1.25 points, or about equivalent to adding one additional type of healthy food to the store. And if you look at the map, you can see the different colors represent quartiles of healthy food availability, and with red dots representing either no change or a decrease in healthy food availability over time, and then the yellow and the two blue dots representing increases in healthy food availability. Further, we looked at what were the predictors of greatest increases in healthy food availability. In our study, we looked at supermarkets, corner stores, convenience stores, and well as corner stores where all foods were sold behind bulletproof glass. And we found the greatest increases in corner stores, which were also the most common type of food store in our sample. And we also found the greatest increases in neighborhoods with greater than 60% Black residents. Further, we looked at the impact of the WIC policy change on healthy food availability. And here we looked only at small food stores because we believed that supermarkets were likely to already meet the WIC requirements as part of the new policy. And here we had looked at a scale from 0 to 11, representing only the types of food in our study that actually were impacted by the WIC policy change, which was fruits, vegetables, bread, and milk. So we had 3 different types of stores in our sample in terms of WIC. We had 51 stores that were never authorized by the WIC program, and they saw a significant increase in healthy food availability of 0.48 points. We had 32 stores that were WIC authorized in both years, and they saw a significant increase of 1.46 points, which was significantly greater than the stores that did not participate in WIC. And finally, 18 stores joined the WIC program between the 2 time points. And they had the greatest increase in healthy food availability, which again was significantly higher than that of the stores that were not WIC authorized. So in our analysis, what we found was that the impact of the WIC policy change was an increase in healthy food availability of 0.73 points, as well as the impact of joining WIC led to an increase of healthy food availability by 1 point. And I just wanted to say that in contrast to previous studies, we had a 3-year time lag between the WIC policy change and when we did our analysis, when our second survey was, and so we're able to look not just at sort of the immediate effects of the implementation and the effort that happened to really make this happen, but what happens over time. Is this able to be sustained? So what are the lessons learned here? So 1, we learned that federal policy can be an effective tool for increasing healthy food availability, at least moderately, in urban areas. And that this is not true just in the immediate aftermath, but that this is true in the longer term. Further, we found that increases in healthy food availability were in areas that need it most. So as I mentioned before, there is unequal access to healthy foods, and we did see greater increases in majority Black neighborhoods as well as in corner stores, which are not known for having a large amount of healthy foods. And then finally, in terms of thinking about what are the implications of our findings, the 2014 Farm Bill includes a mandate for the USDA to take on a rulemaking to increase what SNAP stores that are part of the SNAP program are required to carry. And so this is really important because WIC affects 46,000 stores, SNAP affects 250,000 stores, of which 220,000 are small stores. So this has the potential to really improve healthy food availability across the board in all sorts of stores in this country, and I think it's really important that it be done right.
Okay. Well, let me first say that it is really hard to be last. But the good news is that I followed instructions and I have only 4 slides. And I'm very happy to present this research on behalf of my team. There's 13 co-authors, including myself. So I'd like to thank them, and I'd also like to thank our community partners who are really essential to allowing this study to happen. This was a 5-year study funded by the NIH with extra funds by RWJF. So what we set out to do was to understand what happens when you increase healthy food availability. And our main question was, does building a supermarket in a food desert, a place that has very low access to healthy foods, improve diet? So there's been reference to a policy that that serves to incentivize supermarkets to locate in food deserts. This is called the Healthy Food Financing Initiative. Now, this policy was actually implemented without evidence to show that it really has the power to do anything. There have been very few studies in the United States that have been able to look at whether indeed this policy works in terms of improving diet among residents. The two studies that have, actually Brian Elbel is one of the authors of one of the studies that does exist. The two studies that have happened have been relatively small studies with much less funding than our study was able to acquire. So what we set out to do was to almost make a much more definitive statement by saying, listen, we have 5 years of funding and we have an opportunity here. We have a neighborhood that we know is getting a full-service grocery store. Let me say that the neighborhood is located in Pittsburgh, Pennsylvania, and what we did was we chose a comparison neighborhood. These two neighborhoods are very low-income, racially isolated neighborhoods. They're predominantly African-American neighborhoods. The mean household income per person of our study was $13,600. So these are very low-income neighborhoods. What we were able to do was collect a whole bunch of information at baseline, so prior to the opening of this supermarket, and then a year after the supermarket opened. What we did was we took a complete census of both neighborhoods, of all of the residential addresses in both of these neighborhoods. We then took a random sample. We wanted our sample to be completely geographically representative of the neighborhoods. We combed the streets and identified which houses were vacant or which addresses were vacant. This was a very labor-intensive process. We hired data collectors that were trained that came from both of these neighborhoods. The survey that we administered to all of the households was an hour-long survey. We collected 24-hour dietary recalls. So as I'm explaining this, you can imagine the sort of intensity involved in this study, but we really wanted to be able to answer this question. We also audited all of the food stores, and we audited all of the food stores that people said that they shopped at. So our questions ranged from where do you shop? How much do you spend? How do you get there? To food security, you'll be very happy, and we had the long form of food security, to perceptions of the neighborhood. How satisfied are you with your neighborhood as a place to live? What are your perceptions of crime? What are your perceptions of safety? Okay, now the results. So we asked these questions in 2011 and then again in 2014. What did we find? Well, it was actually a little bit surprising to us that we found a lot of changes, and we found a lot of changes that have not been found before. Why did we find these changes? Well, we asked a lot of questions and we did a very detailed dietary recall. So just to go over some of the changes that we did see, we saw a net positive change in dietary quality. I want to sort of qualify this to say that dietary quality actually went down in both of the neighborhoods. However, it went down much less in the neighborhood where there was a supermarket. Now, caloric intake, we saw a positive change. Added sugars, we saw a positive change of 3 teaspoons per day. These are all changes that went in the improved direction for the intervention neighborhood. Empty calories, there was a positive change. These are all the significant changes. The changes that were not significant were fruit and vegetable consumption and whole grain intake. So there was no net change that was significant between the two neighborhoods, and in fact, in the intervention neighborhood, this went down. The next two major changes were changes in neighborhood satisfaction. So in the neighborhood that received the grocery store, when we asked how satisfied are you with your neighborhood as a place to live, this increased from 66% to 80% of residents who said, I'm either satisfied or very satisfied. We thought that this was an important outcome in and of itself. And then perceived access to healthy foods. So when we asked, how accessible are fruits and vegetables in your neighborhood, how accessible are low-fat products, and how accessible are whole grain products, this rose dramatically. The next sort of surprising finding is that pretty much none of these dietary changes were directly associated with use of the supermarket. So when we further looked at the how often residents use the supermarket, the only one of these outcomes that was associated with use of the supermarket was perceived access to healthy foods. So these changes occurred whether or not residents used the supermarket. So what does this all mean? Well, we think that this actually supports federal efforts to invest in new grocery stores in food deserts for a whole lot of different reasons. We saw change. We did not see change that was related to use of the grocery store, but we saw change. We think that investment needs to be cautious, and further research, of course, needs to be done. We need to understand the mechanisms through which these new stores might be creating these changes that we saw. So I will end there, and thank you so much for staying till the end.
Okay, a few quick questions from me, and then we'll open it up to the floor. Dalia, I want to focus on the first of the two papers you presented. I think for me and maybe for others, the lack of a difference along the race ethnicity dimension is surprising. We know that that residential patterns are correlated with income, but we also know they're correlated with race and ethnicity. And so the suggestion from what I gather out of the paper is that the shopping differences are really an income effect, not a race ethnicity effect. But if they're tied to housing, and we know housing's tied to race ethnicity, I'm just trying to figure out how you interpret that set of findings.
Yeah, well, I think it's a really good question, and it was surprising for us not to find differences. However, I guess one of the explanations here is that it might be that in our sample, the different race, ethnic, and income groups overcome some of the barriers to shop at grocery stores, for example. And one thing that I do want to clarify is that we look at where they are shopping. However, we don't have information on where they live or where the store was located. So this is after they make the decision of shopping at a grocery store, wherever they decided to go. We did this analysis. So yeah, results were surprising, but I think they also communicate something that is very relevant when we think about focusing on grocery stores or supermarkets as places where we could intervene, and not necessarily, like, I know access to food is of course a necessary condition to be able to eat healthy foods. However, it might not necessarily be sufficient to make those changes. So yeah, I don't know if that answers your question.
Sure, that's helpful, thank you. Laura, you show a larger improvement in stores that move from non-WIC to WIC status, and I just wonder if you could help us understand what would cause a store to either drop out of the program or, in this instance, join the program that might have an effect on whether or not that change is a selection effect or is actually the effect of the policy that you examined.
Yeah, sure. I mean, I think, so there's one thing that I wanted to say was there was, in our sample of stores, there was only one store that dropped out of the WIC program, which wasn't included in the analysis because it was so small. And I think that excuse me, that's really encouraging, because one of the things was a concern that maybe these stocking requirements would be too onerous for stores. And so the fact that we only saw one store drop out over the time period and 18 join is pretty encouraging for the WIC program and sort of, being feasible for stores. In terms of what might induce a store to join WIC, I mean, that unfortunately I'm not really sure, but I would assume one of the things that's sort of particular about the WIC program is that it requires stores to stock these, but it also provides people the specific benefits to then buy these items, right? So there is kind of a feedback loop that stores are encouraged to participate, because then people with specific benefits where they say, you get to get this type of food, will use it in the store. And unfortunately, when we think about the applicability to other programs such as SNAP benefits are much broader in terms of they're not restricted, as we've heard earlier, whereas WIC benefits are very much restricted. So how that will sort of, affect this and sort of using this as a model for SNAP, for instance, is unclear.
And Tamara, as I listen to the findings, it makes me think of another institution that we know has very positive effects on communities in this sort of emotional attachment way, even if it doesn't necessarily have the direct effects, and that's hospitals. And we're having a big discussion in this country about how many of them we should have and how to support them in communities that can't necessarily afford them. But one thing we know is that there is this sort of feeling about it defining a community in a way. And so I wonder if that's maybe part of the picture, and whether the duration of the results you find might be affected by sort of this more emotional attachment as opposed to some, direct attachment. As you note, the findings don't show much in terms of effects based on people's use.
Yeah, I think that's a great question, and it's a great analogy. So yeah, when we saw we saw these differences that we had a lot of confidence actually existed. The households enrolled in the study were households that we went door to door and we approached, and this wasn't a selected. There was not selection bias that the most enthusiastic households were part of the study. Yet we saw these changes that weren't related to whether or not residents used the supermarket. This particular neighborhood went 3 decades without having a supermarket, and there was a tremendous amount of sort of community investment in seeing this supermarket locate and open its doors. And it's hard, it was nearly impossible for us to measure the sort of awareness and the sort of the effect of what happened in getting the supermarket to locate. We asked a lot of questions around, do you want a supermarket? Do you plan to shop there? Those types of things. But I think that these harder to measure items that are more sort of investment in community and community pride and hope are certainly part of the story.
We have time for a few questions. We'll take one here towards the back.
Oh, hello. Elliot Markman, Foundation for Advanced Education in the Sciences. I'm looking at the USDA map for food deserts. I know there's different definitions for rural and urban areas. For instance, if it's a supermarket within a mile and not having a car. So I was wondering if there's any studies on place-based, rural versus urban, or any information you found about that.
I'm sorry, place-based what? I didn't.
Oh, rural versus rural
rural.
food, rural food deserts specifically.
Sure, I'll take this. Our study was located in 2 urban neighborhoods, so the food desert definition was more along the lines of there's no supermarket within a mile of where people live. But you're getting to a lot of issues around how do you define a food desert and what does it mean? So if you have a car, does that mean that you're affected as much as someone who doesn't have a car? If you live in an urban food desert, and then rural areas are defined very differently. They're defined, at least by the USDA Food Atlas, as you can be 10 miles away from a supermarket. So one thing I would say is I'm not sure that these findings, I think that our findings would apply to other urban food deserts. I'm not sure that they would apply to other rural food deserts. And I don't know of any studies that it's difficult to do an effective study to understand the impact of eliminating a food desert. So there have been no studies done in rural areas. So that's open territory.
All right, we'll do 2 more questions. Vivica?
Thank you. My question is for Dalia. Great. Everyone did a great job on your papers. Thanks. Your second paper that you talked about, the Walmart's reformulation. So if I understood it correctly, and if we think about the time frame of things, you looked at 2000 to 2014, your analysis. But if we think back on Walmart's pledges, because that's kind of where I'm coming from in terms of a public-private partnership perspective, they committed to reformulating their private label brands about a 25% reduction in sodium and 10% reduction in added sugars in 2011, and then they were going to develop their Great For You icon and influence supply chain practices. But what happened in 2013 is they actually said, well, between 2011 and 2013, we actually reduced our sodium by 9%, our added sugar by 10%, and then they're trans fat. But what I'm understanding from what you're saying is that they actually achieved that reformulation between 2000 and 2007. So when they made that public pledge with Partnership for Health America and Michelle Obama's Let's Move, they already knew that they had achieved those targets. So would you say that it's sort of, taking advantage of inside information they knew to sort of spin their reputation in a pretty good way? And are there efforts for further improvement and reformulation?
Yeah, so I think that's exactly one of the points that the authors of the paper discuss. And basically, yes, what they are saying is that they took advantage of something that they already knew was happening. So can you repeat what you asked at the end?
I guess, do you see there room for Walmart doing further improvements, particularly with this Humana Vitality relationship? It's 1 million people who participate in Humana, and they're saying they're going to provide their better for you or great for you products, their fruits, vegetables, whole grains. Do you see an opportunity for Walmart to actually step up and do good work?
Well, I think there are opportunities out there, and hopefully every store would do something like that. However, this was one of the first studies that actually attempted to measure whether these changes occurred or not, and whether they were because of the HFI. So in terms of what can be done, I think there are a lot of things that can be done, especially with regards to what's offered at the store. We all go there and see a bigger availability of what we would consider unhealthy foods versus healthy foods. So I think there are a lot of opportunities to change, and not only there, but in other store chains as well.
Take our last question in the very back.
Thank you. Barbara Krumgold from the Kaiser Permanente Birch Scholars Program. My question is for Tamara, and I noticed that you did get really positive results in the areas you mentioned of reduction of empty calories and sugars, but you didn't see a move in the needle on consumption of fruits and vegetables. And I remember before you did another study where you looked at immigrants' shopping behavior and the time and distance they were willing to travel to get healthy fruits and vegetables. So my question is, if you continue this study, what would you put in there to drill down to see what it takes to improve diets with regard to a willingness to spend more on fruits and vegetables, and whether you learned anything from the food spending and shopping, the purchasing behavior, or about resources available for spending on food, or cultural habits that would help you explain that or drill down in that area.
Thanks, Barbara. You get at a whole lot of questions here, and basically, I guess I'll answer. So we saw a reduction of bad for you foods, and we also saw a reduction of good for you foods. The good for you food reduction was not statistically significant between the two neighborhoods. So when we compared, we wanted to understand secular changes that might be occurring, and we wanted to be able to attribute any change that occurred to the supermarket. But one of the surprising findings was, this policy exists to try and increase access to healthy foods, and we did not see an increase in healthy food consumption. We saw a decrease in unhealthy food consumption. Well, one explanation is that there was more awareness, and it's easier to potentially decrease unhealthy foods than it is to increase healthy foods. I think you get at the fact that diet and what people eat is the result of a whole host of very complicated predictors, from your neighborhood environment to the in-store marketing environment to your home environment to your palate. So I think I think that if we're truly committed to pushing the needle on the obesity epidemic, and if we're truly committed to trying to say we need to improve diets of populations, and especially of vulnerable populations, we're going to need multi-pronged efforts.
Well, that's a good place to end. I want to, as we finish today, to remind you that this issue and this briefing were made possible only because we had support from the Robert Wood Johnson Foundation, and we are very appreciative of that. December and January at Health Affairs will be variety issues covering a broad range of topics. Next briefing will be in February at the National Press Club, when we will have a thematic issue focused on vaccines, a topic I know all of you are interested in if you're here talking about food and health. And with that, please join me in thanking our final panelists.